Hello, Sam, are you there?
Yes, I am here.
Okay.
Okay.
Welcome.
Thank you, Joe.
Okay, so basically I'll just, we have 15 minutes.
Okay.
Okay, so I'll introduce you and then you just take it from there. You know, you call, you introduce the speakers. Yeah, please ask everyone to introduce themselves. Even when they're questioning, and whenever a neurosurgeon appears on the screen, hopefully they'll introduce themselves. Okay? Okay?
Okay.
But you
Hello.
know that. You know that.
Okay.
So you're posting everywhere. I think you
Yes.
post as much as I do.
Yes, I did. Yes, I did.
Well, you see my posts, right?
Yeah, yes, I have.
Yeah, they're everywhere.
Yes, thank you.
Yeah, well, it's better that way, just to let people know. And most neurosurgeons, they want to hear. So some don't, are not interested. That's fine. Make you call, okay. Okay, you want to because that's no problem. Okay, let me see here.
Okay.
I don't think you're going to use anything. Hold on, attendees. Okay. More, make co-host. Okay.
Okay.
Now this will become useful when we use the polls. The polls. Hello, Sanford. Unmute yourself.
Yes.
Oh, yes.
It's okay now.
How are you, everyone?
Hi, Sanford. I'm Dr. Bennett.
Yeah, nice to meet you.
Nice to meet you. And Sam is here.
Yeah.
So he's going to be leading the program. You've done Zoom before, right? Right, Doc? Well, I guess he took a powder.
I'd like to welcome Professor Sanford and Professor Sanjiva. Welcome, professors.
Hello, hi.
I say.
How you doing? We've televised you before.
Yes,
Yes.
that's right.
I won't call you an old timer.
I'm just going to mute myself.
We can hear you clearly, sir.
Great.
See, Sam, I just put this background on for before we start.
Okay.
It's not professional. I'll put the good one on now.
Thank you.
Yeah. This is business. Right, Sam? This is business.
Okay, but I don't get any money from this work.
Oh, yeah, okay. Yes, we tried a background. I tried to get Yuha to use a background yesterday, but it didn't work. It didn't because sometimes you put these images up behind you. They make them big, they make them small. You never know, So
Yes.
you got to take some time. We're getting some people here, man. Hello, Joanne.
Hi, John. How are you?
Yeah, unfortunately, you know me, so you have to suffer.
Everybody knows you.
How you doing? I'm glad you
I'm
could
fine.
make it.
I'm fine. How are you?
You've been working a lot, huh?
Yeah.
Yeah, I figured.
Mm.
Did you see Yuha yesterday or a little bit,
Yeah.
right?
I did.
Oh, just the end.
It was really good. It was really good webinar.
Oh, he loves it. He loves it.
Yeah.
He loves it.
Yeah.
He's-
Really
he's
good.
like-
Really
he's
good
like a-
combination.
Yeah,
How are you? Have you been
Good.
fine?
good. Yeah. We have a lot of webinars. We have this one, and we have a couple tomorrow with IPE.
Yeah.
And with Nikolai, the Italian neurosurgeon that made the cadaverless anatomy.
Mm.
That's going to be interesting to see.
Yeah. Definitely. Looking forward to. Nice
Yeah,
to be
but-
here.
Yeah, that's okay. We'll talk to you later. Okay.
Okay. Yeah. Bye.
Oh, man. We're going to reach the limit, Sam. Quick. I think. That's great. That's great. A lot of interest. You've done a lot of
Yes.
stirring up of people.
I gain a lot of friends worldwide. That's what I gained.
No, there'll be people watching on the internet. You won't even, they won't be on the panel, but they'll be watching. So.
Hmm.
Yeah, we got 8 minutes.
Okay.
I'd like to try to start them on time. Sometimes it doesn't work. I'm not too rigid about it. Sometimes can't get things working right. While I'm gabbing, I better check to make sure I got this set up on the internet. Okay. Yep, it's all set up. Okay. Is the sound going to you? Can you, Sam, are you there? I don't know if the sound is stuck on me.
Yes, I am here.
Okay, the sound is sticking to
Okay.
me for some reason. I don't know why. Okay, let me unpin. Okay, unpin video. Oh, okay. I was
Okay.
pinning it. Sometimes I've started conferences where I pin myself for the first minute. I
Okay.
can't see anybody.
I'd like to welcome Professor Abida Shah. Welcome, boss.
Hi, Dr. Same.
Thank you.
Hello, Dr. Shah.
Hi, John.
Dr. Shah, you like these webinars.
Yeah,
You like these webinars.
yeah, something to do.
Did you like it? Did you like them before Corona, or is this something you picked up during the Corona?
Before Corona, it was good, but not so frequent because there was not much time to see
Oh,
them.
okay.
I was
Yeah,
busy doing
that's
something or the other.
yeah.
Yeah, but they were good before also, but I guess the time was the factor.
Yeah.
Yeah.
That's it seems to be slowing down the number of ones, but it was going at a pace at first really
Yeah.
fast. It was hard to keep up with everything.
There was something every day.
Yeah, well, a neurosurgeon has an interest, so he doesn't mind looking at them and seeing what's out there.
Yeah,
You don't get overloaded. You just pick what you like.
that's true.
So Sam, okay, excuse me, Sam, I got to let some people in here. Okay, man. Yeah, we got 100 panelists, Sam. Are you there, Sam? I always get nervous at these big conferences, man. I've got a lot of people there. I'm getting nervous now.
I doubt that very much, John.
Mm.
Yeah, original limit. Okay. Are you sharing the screen there, Sama? Oh, he's just putting it up. Okay, that's fine. Just leave it up there. But it gets tricky. Sometimes you can't unpin that. Sam, are you there? Sama?
Yes, yes, I am here.
Yeah, you're screen sharing that. That's okay.
Yes.
That's
Okay.
fine. That's fine. That's fine.
Okay. We are just waiting for our Professor Atul
Well-
Goel.
Yeah, before I start, I'm sorry, what'd you say?
We are just waiting for our Professor Atul Goel to
Okay.
start.
Is he the first speaker?
Okay.
Yeah, he's a veteran. He
Oh.
knows what he'll probably come at the last minute. You know, occasionally he'll have problems with his Wi-Fi, but just be patient and wait. It usually comes right back. Okay, Sama? You might not know that about Dr. Goel, but
John,
we're
I
using-
He is just.
Oh, there he is.
just
There he
in
is. Well, I'm just talking about your internet and how everyone just hangs in there until you come back.
John, now my internet is better.
Oh,
Now
it is.
Yeah, now it is foolproof now.
Oh, good. Well, everyone waited, even though we had delays. So that says a lot. How you been, Dr. Well?
Very good. How are you, John?
Good,
Everything
good.
okay?
Yeah, very good. I see you're staying very active.
Yeah. Very good.
Welcome,
Nice.
dear Professor.
Yes, Dr. Samay, how are you?
I am fine. Great honor to have you today with us.
Thank you very
I
much.
tell you, Dr. Same's done a lot to get this thing together. He's a force to be reckoned with in the Arab neurosurgery education field.
Yes, I know. And he has got a fantastic connection now everywhere in the world.
Yeah,
Dr. Samay is the boss now.
yeah. We'll follow him.
Yes.
Thank you, sir. Thank you.
Thank you, Samay. Thank you.
Okay, 1 minute. Sam, I gotta get that off the screen, okay? I'm gonna boot you off that picture. Okay, because I want to introduce you and see faces.
Sanjeev, how are you?
I'm very well, Atul. How are you?
Nice to see you, Sanjeev.
Oh, nice to see you. I like your background, Atul. It's very cool.
This is this is Om. Do you
Oh, yeah.
and an angiogram with aneurysm. So it is all combined.
Oh, that's excellent. I didn't realize until you said it. Yeah. Very nice.
Where are you,
Yeah.
Sanjeev? You're in Leeds, right?
Oxford.
Oxford. Yeah.
Well, I'm looking forward to your talk. It's a very interesting topic you've got.
Let us see. I hope I keep it up to your expectation.
I'm sure you will.
Okay, we're ready to start, gentlemen. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach, the home of Neurosurgical TV. We are proud to be broadcasting today the EWNC Academy Conference for Surgery on the anatomical jewel box of the Cavernous Sinus with a great lineup of speakers. And I'm going to turn it over to the organizer, Dr. Sama El Morsi. Hello, Sam.
Hi, how are you, John?
Welcome.
Thank you. Thank you. Okay, can I share my screen now?
Yes, it's all yours, Sam.
Okay.
On the fly.
Okay. We will just start now.
That's okay.
Greetings from Egypt. It's a great honor to be with you again here in the Academy family today. Dear colleagues and professors, we will start today our skull-based webinar. And we will start by surgeon on anatomical jewel box, Cavernous Sinus. And before we start, I'd like to answer one question. Why we have to join Ewins Academy? To answer this question, we need to take a small tour inside Ewins Academy to know why it's unique. Please allow me to take you in a small journey inside it. Let's start shipping. Ewins Academy is a virtual simulation of real best medical college with extra features of extraordinary number of staff members that can exceed the biggest department in reality. 17,000 of selected refined members. At first stop of our journey, we will meet at the beginning the logo of Ewins Groups. Logo has been carefully selected to show that neurological surgery is like a big puzzle that we are collecting every day a piece of it for you to give you more clues of this puzzle. Second step is why we have chosen Telegram program, specifically to help us in our mission. As we have learned from neurological surgery that we have to prepare meticulously to our surgeries to get the best results by choosing the best tools, which is Telegram, that can have up to 200,000 of members in our group and and unlimited data uploading. The best team who are great believers in our ideas and have initiatives to gain with us the best desirable results. That's why for more than 4 years, we have been close watching every member activities to choose the best leading team for Ewins. And we still including the best members to be leaders in every group according to their interest. Why 33 groups? Our youngers said that we can't follow all messages in main group because of high flow. That's why we separated content to 5 groups. Then, as in reality of new surgical departments, when we got all these numbers of active members, we thought about making subspecialty groups to be more specialized. You don't have to follow all these groups, but you will find in these groups all what you are interested in to follow with variable contents that are suitable for masters and youngers. 33 groups will make you fully saturated from updated neurological surgery that will be suitable for you in every stage in your career. Collaborative work is the best thing that make Owens special and made name that we all proud of it. Leading huge groups like Owens is not an easy job at all. It makes us always care about every fine detail and also every single word to be sure that we are on the right way. You can't lead it if you can't read all these statistics and refine it to exclude false, biased numbers and watching all numbers all the time to bring the enthusiasm and zeal to learning of such sophisticated subspecialty. Team active, enthusiastic work is the special thing that build up great name like Owens. It is not a one-man show at all. And thanks to teamwork, we have about 400 members interested in attending this session before it starts. I'd like to thank organizers of this webinar, Dr. Achal Gupta, Dr. Amu Hazim, Dr. Muhammad Hilmi. At last, I'd like to invite you all to join us in our next event, 4th and 5th September 2020 at 15 GMT, which will be that time just like now. First session of Owens Academy Neurovascular Series. And now, proudly let me introduce to you our moderator of session, Professor Sanjeeva Jaretna, Director of Oxford University Hospital Skull-Based Surgery Program, Fellow of Royal College Surgeons of England. His clinical practice focuses on surgical treatment of complex skull-based lesions with open and endoscopic techniques. Collaborated with scientists Oxford University on translational research models of brain tumors. His current research interests are in developing and integrating artificial intelligence technology into the skull-based surgery service at Oxford. Thanks dear mentors, professors, and colleagues for always supporting our family of Owens Academy. Please, Professor Sanjeeva, the moderation is yours. Thank you.
Sami, thank you very much. Thank you for that very kind introduction and for organizing what looks like an excellent lineup of speakers and a very, very good program. So it must have been a lot of hard work. So thank you for setting this up on what's a very important and challenging topic. Cavernous sinus surgery, as we know, is technically very demanding, and understanding the concepts, when you should operate, when you shouldn't, and how you should do it is very important. It's a real pleasure to be here and a pleasure to introduce our first speaker, who's Dr. Abida Shah, who is the assistant professor at GS Medical College and KEM Hospital. I believe that's where she did her residency and was chief resident. Also underwent fellowship training at the Mayo Clinic in endovascular surgery, and I see that she has got a very active research interest as well, in addition to her practice in skull base and neuro-oncology. She is the Indian Society of Neuro-Oncology's President Award winner for clinical research in 2019, has over 100 publications, and is also a keen educator as the ACNS Women in Neurosurgery Education Chair. So it's a real pleasure to introduce Dr. Abida Shah, who will be talking to us about the anatomical concepts, which will be a fantastic introduction to this, I'm sure, very good session. Dr. Abida Shah, thank you for joining us.
Thank you, Dr. Sanjeeva, for this kind introduction. And thank you, Dr. Samir, for this invitation for this webinar today. So I'm going to be talking about surgical concepts and anatomy of the cavernous sinus. I would like to acknowledge my friend and colleague, Dr. Sukhdeep Jawar, who has provided me dissection images for this talk, and you will see how beautiful they are. So let's begin. The cavernous sinus, as you know, is located in a very strategic location of the center of the skull base, as you can see here. The reason for this strategic location can be manifold. It has within its confines the internal carotid artery and a great venous plexus. It is adjacent to the sphenoid sinus. It is adjacent to the pituitary gland. It basically, the location helps to maintain the external and internal milieu of the brain and homeostasis of the entire body. I believe that is the reason for this location that has been chosen for the cavernous sinus. And because it is located in so much of the center of the skull base and in its depth, it is difficult to approach surgically, and it is well protected by a multitude of layers, as we will see as we proceed further. So this beautiful image that you see here is that of the Carlsbad cavern in New Mexico. So what is cavernous? What does the word cavernous mean? It means a cave or a cavern. It means depth. It means that this is an inner chamber or a cave or cavern in the most inner aspect of your body. So just as you can see here in this, there are so many transgressions that have been made to reach the inner chamber of the cavernous sinus. And I like this picture because it kind of shows all the layers that are there to study the anatomy of the cavernous sinus. I simulated them to mean the meningeal layer of the dura, the endosteal layer of the dura. You have the cranial nerves in this area. You have the abducens and the internal carotid artery in the center of the cavernous sinus. And this hole that you see relates to the sphenoid sinus. Another analogy that I would like to start before I start with the anatomy of the cavernous sinus is, I would like to take it as a house. You have this house where it has a wall, that is your first layer of the cavernous sinus. You have a door that makes you enter the first layer. Then you have this outer chamber of your house where you have the living room, where you may have an attic or a roof, and you have a basement. Then you have this inner chamber that is your bedroom, that is the cavernous sinus proper. And this is your backyard, which I will explain later. So this is a coronal section of the cavernous sinus. And you can see here as the layers that I described. So this is your layer of the meningeal and the endosteal dura. This is your first layer, your door to enter the house. This is the outer chamber of your house where you have a roof or the attic, where you have the outer living room, and where you have a basement where some cranial nerves traverse, as we will see in the dissections. And this last inner chamber that is protected and that is divine is your cavernous sinus proper, which has the internal carotid artery and on the lateral aspect, the abducens nerve. And this region here is the sphenoid sinus, and this is the pituitary gland. Now let's look into these layers one by one. So before we start, we see the osteology in relation to the cavernous sinus. So this blue structure here is the cavernous sinus. It extends from the superior orbital fissure and goes all the way posterior to the petrous apex. This bony landmark is one of the most important landmarks for surgery in the region of the cavernous sinus. And this is the anterior clinoid process. As you can see, it has three roots. This is the base of the anterior clinoid process, where it joins with the lesser wing of the sphenoid. This is the anterior root, and this is the posterior root. The anterior root forms the roof of the optic canal, which you can see here. And the posterior root is very commonly known as the optic strut. And it runs in between both the anterior and the posterior roots, run the optic nerve and the ophthalmic artery as they enter this canal. The other bony landmarks that are important in this region are, this is the superior orbital fissure, this is the foramen rotundum, this is the foramen ovale, this is the foramen spinosum. This small foramina here that you see is the foramina for the emissary vein, which connects the pterygoid venous plexus to the cavernous sinus. This sulcus that you see here is where the carotid artery runs, just medial to the base of the, just lateral to the base of the sphenoid. And this opening here is the foramen lacerum. So when you study the cavernous sinus, the first important thing that you want to know is the dural walls of the cavernous sinus. So this is a schematic representation of the walls of the cavernous sinus. Basically, it is made, the cavernous sinus is between two layers of dura. It is between the meningeal layer that runs along the cerebral surface and the endosteal layer which lines the base of the middle cranial fossa. So these two layers split, and in that space is your cavernous sinus, this blue structure here. So this yellow layer here depicts the meningeal layer. If you peel this outer layer of dura, you can get a direct access to this region of the cavernous sinus. And the pink structure here is the endosteal layer. And as you can see, it is continuous with the various other dural demarcations of the middle and the anterior and posterior cranial fossa. This structure here, this ring-like structure here, depicts the cranial nerves. The endosteal layer of the dura, as soon as the cranial nerves enter the sinus, they're covered with this endosteal layer of dura. So between the cavernous sinus proper and the meningeal layer, where the cranial nerves are, they are embedded in a layer of endosteal dura, and it is this region that helps us to access the cavernous sinus. So as you can see in this dissected specimen, this is the dural layer. These are the cranial nerves as they are entering into the dural cave. It carries with this layer of dura, and it covers on the anterior, on the lateral and the medial aspect. You have a dural covering over all the nerves as they enter the cavernous sinus. So this is the fifth cranial nerve, this is the oculomotor nerve, and this is the trochlear nerve. All of them, as they enter, they carry a dural sleeve with them, and that is always present within around the cranial nerve. So this is a specimen where the meningeal and the endosteal layer of the middle cranial fossa floor has been removed. The dural layer, some part of the dural layer over the cranial nerves has been preserved. And this is the access that you get when you peel off the outer layer of the middle fossa dura. And when you come in this region, this is how you will access the cranial nerves. And these are the various locations, as we will see, how you enter into the cavernous sinus. So let us begin. So this is the superior view of the cavernous sinus. This is the lateral wall of the cavernous sinus, the superior wall of the roof of the cavernous sinus, the posterior wall of the cavernous sinus, and the anterior wall, which cannot be seen very clearly here. The medial and the lateral borders of the cavernous sinus meet here below the carotid sulcus, and they join together. The superior wall of the cavernous sinus, or the roof of the cavernous sinus, houses the oculomotor nerve and the trochlear nerve. It is continuous with the dura of the anterior clinoid process. It continues over the base of the anterior cranial fossa. It continues over the planum sphenoidale, goes over the tuberculum sellae region, and continues as the diaphragma sella, which again, coming below this supraclinoid ICA segment, will come down and form the medial wall of the cavernous sinus. So this part of the dura on the posterior side has been removed, and you can see the basilar venous plexus. So the main important triangles on the superior wall of the cavernous sinus are the clinoidal triangle and the oculomotor triangle. So the clinoidal triangle lies between the optic nerve and the oculomotor nerve, and the base is the anterior clinoid process. Its content is the clinoidal segment of the internal carotid artery and the optic strut anteriorly, and some part of the roof of the cavernous sinus. The oculomotor triangle is formed by the anterior petroclinoid ligament, which runs from the anterior clinoid process to the petrous apex, the posterior petroclinoid ligament, which runs from the posterior clinoid process to the petrous apex, and the interclinoidal ligament, which connects the anterior and the posterior clinoid processes. So this is your oculomotor triangle. As you can see, the oculomotor nerve enters in the center of this triangle. It carries with it a layer of arachnoid, which forms an oculomotor cave or an oculomotor cistern, which has been described by Professor Goel. Also, you can see this vessel, this artery that comes, which is very consistently found in this location, and it is the meningohypophyseal branch of the cavernous segment of the carotid artery. The trochlear nerve, as you can see, enters the posterior lateral segment of this triangle, of this oculomotor triangle. This is where the trochlear nerve enters. this connection, this layer that you can see here is the tentorial edge, and the trochlear nerve is running right medial to the tentorial edge. And this is your fifth nerve as it enters into the Meckel's cave. Now, as we go further, the optic nerve has been lifted up, and you can see the ophthalmic artery is entering from here. It usually mostly arises from the supraclinoid ICA. Very rarely it has an origin in the cavernous segment of the ICA. So as you can see the dural layers, this is the falciform ligament. This is the portion of the dura that is continuing on the planum, on the tuberculum, and as the diaphragma sellae. You can see the pituitary gland with the pituitary stalk. And this is the so we have seen the roof now, and this is the posterior wall of the cavernous sinus. And you can see here, part of the wall has been removed to expose the basilar venous plexus. And we'll look into this location now. So now the dura over this region has been removed. And what you can see here is this ligament here. This is the Gruber's ligament or the pitrosphenoid ligament. And you can see the sixth nerve that is entering below this into the Doral's canal. Again, you can see the oculomotor nerve. You can see the trochlear nerve. You can also see the venous plexuses of the cavernous sinus. So the cavernous sinus is divided into a medial venous plexus and a lateral venous plexus by the presence of the internal carotid artery. Usually the medial venous plexus is larger than the lateral venous plexus. Sometimes the lateral venous plexus is very small, and sometimes these nerves are quite closely running with each other to leave very small space to have these venous sinuses. So this is the medial part, this is the lateral part. Then the superior petrosal sinus runs across here at the edge of the petrous bone, which I will show you in another image. And this is the confluence of the basilar and the cavernous sinus, and below the inferior petrosal sinus. So these are some branches of the dorsal clival artery, which are branches of the meningohypophyseal trunk and supplying the dura of the posterior fossa. And here you can see the dural layer of the fifth nerve has been removed to see the fifth nerve in the lateral wall of the cavernous sinus. So what are the two triangles in this region? So there are 10 triangles in the cavernous sinus. We've already seen 2 in the roof, and now we have 2 in the posterior wall. You have the inferolateral paraclival triangle and the inferomedial paraclival triangle. So this inferolateral triangle, the edge is formed by the connections, dural margin which runs between the trochlear and the abducens nerve. The superior border is where the petrosal vein joins the superior petrosal sinus, and the inferior border is the dural border that is running, you can see here. And the content of this triangle is the trigeminal nerve as it enters into the lateral wall of the cavernous sinus. And the medial triangle, again, the lateral border is the same, which is the medial lateral border of this triangle between the trochlear and the abducens nerve. The medial border is the dura that is running from the dorsum sellae again to the trochlear, and the superior border is a line joining the posterior clinoid process to the trochlear nerve. And the most important content of this triangle is the abducens nerve as it enters below the pitrosphenoid ligament. So as we go further, this is a closer view. And when you drill in this area, what do you get? You get this region. You need to expose. If you want to expose in this region, you'll get the content of the sixth nerve and the basilar venous plexus. In the inferolateral triangle, you need to expose the fifth nerve. Superiorly, if you go again, some people divide these triangles into 2 parts: a tentorial triangle and an osseous triangle. The tentorial triangle houses the trigeminal nerve, and the osseous triangle is the posterior aspect of the Kawasai's triangle. So we've seen the superior wall, we've seen the posterior wall. Now let's come to the lateral wall of the cavernous sinus. And you can see this dural layer here, extending from the superior orbital fissure to the petrous apex. This dural layer is actually common between the Meckel's cave and the lateral part of the cavernous sinus. So the posterior part of the cavernous sinus actually lies medial to the trigeminal impression, or where the Meckel's cave rests on the petrous bone. As you can see, this is the tentorial edge. This is the oculomotor and the trochlear nerve as they enter into the cavernous sinus roof, just below the level of the tentorial edge. This is the supraclinoid internal carotid artery, and this is the optic nerve. So now we have peeled off the dura of the lateral wall of the cavernous sinus. Both the dural layers have been peeled off. And what do you see? You see all the nerves in relation to the cavernous sinus, and you see the venous spaces. So again, to review, this is the tentorial edge. This is the oculomotor nerve as it traverses from the roof into the region of the superior orbital fissure. This is the trochlear nerve. It is coming medially and going into the superior orbital fissure. This is the V1 division of the trigeminal nerve. This is the V2, the maxillary division of the trigeminal nerve. And this is the V3 as it's going into the foramen ovale. The V3 does not constitute a part of the lateral wall of the cavernous sinus, as it exits from the gasserian ganglion and immediately goes into the foramen ovale and goes into the infratemporal fossa. This here is the middle meningeal artery as it enters the foramen spinosum. And during surgery, I believe this is the key to opening the cavernous sinus lateral wall. Once you coagulate and transect this, it is very easy to peel off the dura of the cavernous sinus and reach into this location. So again, this is the lateral view, closer view of the lateral wall of the cavernous sinus. So let's see the venous structures in this image. So this venous plexus here is as the superior ophthalmic vein joins into the cavernous sinus. It runs between the ophthalmic and the maxillary division of the cavernous sinus. So this is the superior ophthalmic vein joining the cavernous sinus. This is the posterior portion of the cavernous sinus, and the superior petrosal sinus runs into this region and joins the posterior part of the cavernous sinus. This is the part of the venous plexus that is lateral to the carotid artery, and this is the part of the venous plexus that is medial to the carotid artery. And these are the nerves in the region. This is the anterior clinoid process. Now, as you lift the V1 division, you will see the sixth nerve, which runs lateral to the carotid artery and just medial to the V1 division of the trigeminal nerve. So this is the sixth nerve as it is entering the superior orbital fissure. And these are again the venous plexuses. Here you can see the tentorial artery, which is branch of the internal carotid artery. We will see it later. Now the tentorial edge has been cut. This is the anterior petroclinoid ligament that has also been cut. And you can see the oculomotor nerve as it is entering from the roof into the superior orbital fissure. You can see the trochlear nerve as it is entering the superior orbital fissure. This is the V1 entering the superior orbital fissure. This is the V2. And now the ganglion has been turned forwards. You can see the trigeminal impression. And here you can see the posterior part of the cavernous sinus, which is medial to this gasserian ganglion. So this is your whole posterior part of the cavernous sinus. They share a wall. The ganglion here and the posterior part of the cavernous sinus share a common dural wall, which when peeled, we will get this image. So now all the venous phases in this image in the cavernous sinus have been removed, and all you have are the nerves and the internal carotid artery. Here the anterior clinoid process has been removed to again visualize another important aspect of the cavernous carotid artery. And this is the clinoidal segment of the cavernous carotid artery. You can see that there are two dural layers here. This is a dural layer that is coming from the anterior aspect of the anterior clinoid process. This is coming from the lower aspect of the anterior clinoid process. And this is your upper and this is your lower dural ring. The lower dural ring curves upwards and forms a cuff of dura around the carotid artery, and that is your carotid collar. The carotid artery is very densely adherent at the upper dural ring, and it is loosely adherent at the distal or at the lower dural ring. So this is when your ACP is removed. So when you are drilling the anterior clinoid process, extradurally, intradurally, the structures that are in danger are, one is of course, the internal carotid artery. And the next structure which is in imminent danger is the oculomotor nerve. You see how close it is running to the anterior clinoid process. It just lies medial and inferior to it as it enters the superior orbital fissure. So this is the oculomotor nerve. This is the trochlear nerve. This is the V1. This is the V2. This is the V3. And this is the middle meningeal artery. And this is the cavernous carotid. We will discuss it further. So now to see the triangles in this area. So we've done the triangles of the superior roof of the cavernous sinus. We've seen the triangles in the posterior wall of the cavernous sinus. Now let's see the triangles in the lateral aspect of the cavernous sinus. So this is your triangle between the oculomotor and the trochlear nerve. This is your supratrochlear triangle. This is your triangle between the trochlear nerve and the V1, This is your Parkinson's triangle or the infratrochlear triangle. This is your anterior medial triangle, which lies between the V1 and the V2. It is also known as Mullen's triangle. And this is your anterolateral triangle, which lies between the V2 and the V3. So what do these access, what structures do these triangles access? We will discuss at the end of the presentation. And the last two triangles which are remaining are at the posterior aspect of the cavernous sinus. And you have the posterolateral triangle, which is formed by the border of the GSPN, the part where the GSPN enters below the V3, and the anterior part connecting these two areas. And the content of this triangle is the middle meningeal artery. And this is the posterior medial triangle or the Kawashi's triangle. And you have the border as the maxillary, as the mandibular nerve distal to the entry of the GSPN. The inferior border is the GSPN. And the posterior border is actually the line connecting your petrous apex to the fallopian tube, to the hiatus of the fallopian tube. So this is your lateral aspect of the cavernous sinus. Now let's see the cavernous sinus proper. So we've done the roof, the posterior wall, the lateral wall. Now we have come to the innermost part of the cavernous sinus, your innermost chamber, and that houses the carotid artery. So this is where the carotid artery enters into the cavernous sinus. This is the petrolingual ligament from foramen lacerum as it goes beneath this and enters the cavernous sinus and turns upwards, has a posterior bend, and then moves forward. So here the oculomotor nerve has been retracted anteriorly, the V1 has been retracted laterally, and this nerve that you can see here is the sixth cranial nerve as it is entering below the petrosphenoid ligament into the Doralus canal and then into the cavernous sinus. Some nerves that you're seeing running medial to the abducens nerve are the sympathetic plexus, which runs with the carotid artery. They give fibers to both the sixth nerve and the V1 division, and which carry the sympathetic supply to the orbit. Here the ACP is maintained still, and the clinoidal segment will be just medial to the anterior clinoid process. So now everything is completely exposed. You can see the petrous carotid as it is going below the petrolingual ligament. So the parts of the cavernous sinus are the posterior ascending part, the posterior genu, the horizontal part, and we'll see in the next image you have an anterior genu and the anterior ascending part. So again here, this part is covered by the anterior clinoid process, as you can see here. This is the fourth cranial nerve as it is entering the superior orbital fissure. The oculomotor nerve has been retracted anteriorly. This is the sixth cranial nerve, which is running lateral to the ICA and entering the superior orbital fissure. And this is your V1. This is your V2, and the V3 has been pushed anteriorly. So what are the branches of the cavernous part of the carotid artery? So you have basically the meningohypophyseal trunk, you have the inferolateral trunk, and you have the capsular arteries. So on the lateral aspect, you usually see the meningohypophyseal trunk, which divides into the inferior hypophyseal artery, the tentorial artery of Bernasconi Casanari, and the dorsal clival artery, which we saw in the previous image. I can show you again. So this one going here is the inferior hypophyseal artery as it is going to the pituitary gland. This is your tentorial artery as it is running laterally, and the branches running to the posterior dura is the dorsal clival artery. And here you can see all the segments of the artery again, the posterior ascending, the posterior genu, the horizontal, and now the clinoid process has been removed here to see the anterior genu and the anterior ascending portion of the cavernous artery, cavernous carotid artery. The region around this medial part of this clinoidal segment has venous plexus, even in this area, just beneath the carotid collar, and that is the clinoidal venous plexus. So this is the posterior view of the carotid artery and the cavernous sinus, where the entire dural layers have been removed, and you can see the structures elegantly. So here you have the tentorial artery, you have the inferior hypophyseal artery, you have the dorsal clival artery, the petrosphenoid ligament, where Gruber's ligament beneath which the sixth enters, the oculomotor nerve, the fourth cranial nerve, the V1, the root of the trigeminal nerve as it is entering to the Meckel's cave. This is your petrous part of the cavernous carotid artery. And this is the pituitary stalk and the pituitary gland. The diaphragm has been cut here. And this portion here is the medial wall of the cavernous sinus, which has not been very clear in dissection studies. And it is quite many times dehiscent, which explains the traverse of the tumors from the sphenoid, from the medial compartment into the middle part of the cavernous sinus. So now we have seen the microscopic views of the carotid artery. Now to study the most medial aspect of the cavernous sinus, we have used an endoscopic view. So you can see the view from the endoscope, which is showing the dural layers. This is the anterior intercavernous sinus. This is the carotid artery. This is the medial compartment of the cavernous sinus. And then there is a lateral compartment. Here you can see the basilar venous plexus. Removing the dura further, you can see the entire basilar plexus. You can see the anterior internal cavernous sinus as it communicates with each other. There is a posterior intercavernous sinus also. When they all run together, they form a circle here, which they called circular sulcus. But Dr. Goel likes to call it the circle of relief, as he will show in his presentation later. And this is your carotid artery bilaterally. And this is the median nerve as it runs from the pterygopalatine ganglion to the lateral segment of the carotid artery. This branch that you see here running from the medial aspect of the carotid artery and supplying the capsule of the pituitary is the McConnell's capsular artery. As you can see more clearly in this image, as it is running towards the pituitary gland. Now this region here, which is another important landmark during endoscopic surgery, is your opticocarotid recess. This is the anterior, it corresponds to the post-optic strut from the anterior aspect. And you have the upper and the lower dural rings that you can see in this region. It's just lying lateral to the internal carotid artery here. And this is the ICA. This is the medial compartment and the lateral compartment of the cavernous sinus. Now, when you deflect the internal carotid medially, you will start seeing the lateral compartment and the lateral wall of the cavernous sinus. And you can see the various nerves. Here you can see the sixth nerve, which runs with the carotid artery, but the carotid has been deflected medially. This is the V1 and the V2 in the lateral aspect of the wall of the cavernous sinus as it is running down. And this is the third cranial nerve as it is entering the roof of the cavernous sinus. This is the V1 and V2. And you can see the carotid artery has been pushed here. Here you can see again, there are some sympathetic fibers that run from the sympathetic plexus around the carotid artery and go on to supply the sixth nerve and some portion of the V1. So now coming back to this overview of the cavernous sinus, this is again the lateral wall of the cavernous sinus with all the triangles. You can see the supratrochlear triangle, the infratrochlear triangle, the anterior medial triangle, the anterolateral triangle, the posterior lateral triangle, and the posterior medial triangle. Now, why study these triangles? Even though cavernous tumors displace the cavernous sinus or cause a bulge in the cavernous sinus, the triangles are bound by fixed neural landmarks. So if you follow the landmarks, you can still identify the triangles and make your entry into the cavernous sinus. So these are the structures that you will be able to access when you enter the various triangles. So if you go here, you have the oculomotor and the trochlear nerve. So if you access the infratrochlear triangle or the Parkinson's triangle, you get an access to the posterior genu of the internal carotid artery, and generally also the meningohypophyseal trunk. This was the route that was used by Parkinson to treat carotid cavernous fistulas because he believed they arose from this region most commonly. When you go into this triangle, the anteromedial triangle, if you access this triangle, you will get a direct access into the sphenoid sinus. Similarly, in the anterolateral triangle, you will also be directly entering into the sphenoid sinus, into the sphenoid bone here. Accessing the clinoidal triangle here gives you access to the clinoidal part of the carotid artery, just medial to the anterior clinoid process. The posterior lateral triangle and the posterior medial triangle. So posterior lateral triangle, you have the foramen spinosum with the middle meningeal artery. The posterior medial triangle, the Kawashi's triangle, is the triangle that is broken into to get into the petrous region or the posterior cranial fossa, where you do an anterior petrosectomy. And it gives you access to the petrous segment of the ICA and the GSPN here. And here you can see when you go further, it will give you access to the clival region, and further down here on this lateral aspect, the region of the cochlea. So this is again another region, another view that shows the facial nerve as it comes and geniculate ganglion and the GSPN. This is the fifth cranial nerve as it is entering the lateral wall of the cavernous sinus coming from the posterior cranial fossa. This is the region of the cavernous the clivus. These are the semicircular canals. This is the floor of the middle cranial fossa. This is your middle meningeal artery, which if you cut, you will be able to access this region and enter these areas. This region here between the V2 and V3 is the most common site where you enter to approach lesions of the cavernous sinus when you're approaching from lateral. So why did I get this division into these layers, or as I called it, the house? Because the significance comes when you're discussing the pathology of the lesions in the cavernous sinus. So we'll see them, as you see, we'll see the tumors that originate in this layer, the tumors that come in this portion of the cavernous sinus, and the tumors that come in this portion of the cavernous sinus. Quickly, we will just go through them. So this is a cavernous meningioma, which is from the lateral wall of the cavernous sinus. It is just attached to the lateral wall of the cavernous sinus. It does not enter into the cavernous sinus, as you can see this coronal image. So this is your first layer where it is arising from your wall of the cavernous sinus. And this is your tumor. Then this is a tumor that is arising in the region of the anterior clinoid process, where it goes again around the anterior clinoid process, around the lateral wall, but still does not transgress into the medial part of the cavernous sinus. There's another tumor which is growing on both the sides of the cavernous sinus, as you can see in this coronal image. It is going on the medial aspect of the dura of the lateral wall of the cavernous sinus. And this is another tumor that is also going, it is arising on both sides of the dura, the lateral aspect and the medial aspect. So these are tumors of the first layer of the cavernous sinus. And here you can see here how it has engulfed completely. It is originating from the dura of the lateral part and the medial part of the cavernous sinus. And this is a cavernous meningioma, which is an extensive meningioma. So what comes in the second layer? Here you have the tumors that arise from the cranial nerves. So you basically have the oculomotor nerve, neurinomas, you have the trigeminal schwannomas. So this is a typical dumbbell-shaped trigeminal schwannomas as it enters from the posterior fossa and the middle fossa. It's going through the area of the trigeminal porus or the Meckel's cave. And you can see this image as it is entering occupying both the middle and the posterior cranial fossa. And this is another trigeminal schwannoma, which is just occupying the middle cranial fossa, which is present in the interdural layer between the meningeal layer and the endosteal layer of the cranial nerves. And I told you about the basement. So what happens is when the cranial nerves exit the cavernous sinus. So if you have tumors that go along the ophthalmic division, you have this trigeminal schwannoma with an extracranial extension along the ophthalmic division, as you can see here. Then you have this neurinoma, which is extending along the maxillary division and going downwards here. And you have a tumor which can extend along the mandibular division. So this is the basement of the cavernous sinus, but that is also important to realize because you have tumors going from the cavernous sinus into the basement. And these are the intrinsic tumors of the cavernous sinus proper. So you have a cavernous hemangioma of the cavernous sinus, which you can see here is occupying the cavernous sinus proper and bloating the medial and the lateral walls, which it will not transgress, but will occupy the entire extent of the cavernous sinus. This is again another cavernous sinus hemangioma of the cavernous sinus. And then the last thing that you have are aneurysms or caroticocavernous fistula that arise from the internal carotid artery. So this is a traumatic pseudoaneurysm of the ICA, as you can see this connection here after a road traffic accident, which we have treated with a flow diverter and a coil to protect the fundus of the aneurysm. Then you have aneurysms of the cavernous segment of the ICA, which can be just ligated by taking the parent artery if you have a good cross flow. Then you have these kind of cavernous ICA aneurysms, which earlier we used to treat by high flow bypass. As you can see here, a bypass has been done to revascularize the MCA. But nowadays, I'm treating them endovascularly. You can see this cavernous ICA aneurysm, which has been treated with a flow diverter. This is the immediate stasis that you see after deployment of the flow diverter. And this is a delayed image where you can see the reconstruction of the complete internal carotid artery. Here you can see the flow diverter. I'm not sure if you can see the image, but this is the pipeline device. This is another cavernous sinus ICA aneurysm, which is, you can see that the wall is dehiscent here and the cavernous ICA aneurysm is occupying the whole cavernous sinus. This is during deployment of the flow diverter. You can see the immediate stasis after deployment. And this is again a delayed image showing the complete remodeling of the internal carotid artery without any problem. And the last compartment, the medialmost compartment, which can be accessed from a transnasal route or an endonasal route, are pituitary tumors and chordomas. So these are a pituitary tumor, as you can see here, extending into the roof of the cavernous sinus, the medial part and the lateral part around the carotid artery. So which are used by a transsphenoidal route or an endonasal route to treat these tumors. And this is Dr. Goel's classification of pituitary tumors. And this is the grade 2 tumor, which is occupying the cavern, which is going into the cavernous sinus, as you can see here. And this is a grade 3 tumor, which elevates the roof of the cavernous sinus, which goes into the cavernous sinus and elevates the roof of the cavernous sinus. And all are treated by the transsphenoidal route. And the last tumor that comes in this region commonly is the tumor that arises from the clivus. It is subcavernous sinus, displaces the cavernous sinus. This is the chordoma, as you can see here, arising from the cavernous in the from the clivus in the subcavernous region. This is the picture. And this is another chordoma, which has been treated by a transsphenoidal route from the medial back door entry into the cavernous sinus. This is another chordoma of the clivus, which has been treated by a transsphenoidal route. And that ends my lecture. Thank you very much.
Well, Abida, thank you very much. It was an absolutely fantastic lecture. Very, very impressive dissections. I think Professor Goel and I were commenting in the chat. Very beautiful dissections. Some of the best I've seen of the arteries coming off the cavernous carotid and the plexus. Very,
excellent, excellent.
Can I see that? Well, while we see there are any questions, can I ask a question? Some of the people joining us may be quite junior, and I'm sure.
I can't hear you, Sanjeeva, you're muted.
Sorry.
Yeah.
Sorry, I don't know where I left off. But anyway, very, very beautiful dissections. And while we're asking for questions, can I just ask, a lot of people joining us may be quite junior, and I'm sure we're going to cover this in the next two talks, but do you want to talk briefly about the anatomy when you're entering to the cavernous sinus, about the dura propria, the dura around the cranial nerves, maybe just very briefly to give us introduction to the next two talks?
Okay, so there is some, if you want to understand the dura of the cavernous sinus, you first take that there are two layers, just like any venous sinus. The dural layer split, and between the layers of the dura, you have a venous sinus. It is the same with the cavernous sinus. Only thing is you have a meningeal layer that is going underneath the temporal lobe, and you have an endosteal layer which is covering the middle cranial fossa. This endosteal layer covers the whole middle cranial fossa. What happens is, where the cranial nerves enter, they carry along with it a dura. So it forms another layer, which is a vertical layer, which runs along with the cranial nerves. And this is what is also a part of the endosteal layer of the dura, but it is the one that is running with the cranial nerves. It is very thin. So your outer layer is going to be thick. That is the one that you're going to be able to peel off. And once you start peeling off, you will see the thin layer of the dura along with the cranial nerves. This is your endosteal layer, but it is a thin layer, which is running with the cranial nerves, which actually blends into the perineurium of the cranial nerves.
Excellent. It's a nice entry point, isn't it? Now, there's been a question about hemostasis, but I think we'll let our later speakers answer that. So I'll just take one last question before we go to the next talk. That's from Subhya Tripathi, who's asked the surgical significance, one more time again, please, of Parkinson's triangle, is what she's asked.
So Parkinson's triangle was described by Dwight Parkinson, and he used it basically to access a direct access for caroticocavernous fistula. So what it exposes is, it runs between the oculomotor nerve and the trochlear nerve. It runs infratrochlear, so between the trochlear nerve and the V1, and it exposes your posterior bend of the cavernous artery and the meningohypophyseal trunk. So he believed this was the site where the caroticocavernous fistula occurred most. So this is how it is easier to access this region here. So even now, if you want to access the posterior bend of the cavernous artery, this is the triangle that you will go into.
Well, thank you very much. I think we'll, in the interest of time, we'll move on. I'm sure there's lots more questions. It's a very, very good talk. Obviously, we're recording this on YouTube, so everybody can watch it again, which I'm sure will be very useful. So I'm going to move on now to Professor Sanford Hu from Taipei, who's going to be talking about the clinical applications of cavernous sinus approaches. Professor Su is the Director for Neuro-Oncology and Cerebrovascular and Skull Base at Taipei Veterans General Hospital. He's also an assistant professor at the National Yangming University. He trained in the same hospital where he's now become the director there. He's got an extensive research experience, as I'm sure you're all very aware, but including some work he's done with Professor Ali Krishan Al-Mefti. So I'm sure that will stand him in good stead for what's going to be an excellent talk, I'm sure, on the clinical application of the cavernous sinus and its approaches. Thank you again for joining us, Professor Su.
Yeah, thank you, Dr. Sanjiva and Dr. Shen, who invited me to this great event. And at the beginning, I would like to introduce myself shortly. I came from Taipei Veterans General Hospital in Taipei. And actually, I did a fellowship 2 years at UMS in Little Rock. And my 3 great mentors, I was lucky because I have Professor Yashagil, Professor Mafti, and my mentor, Dr. Krish. They are all laureates of the Oliver Crowne Award. I learned the microsurgical concept and techniques from Professor Yashagil and skull-based techniques from Mafti. And also I learned aneurysm techniques and cavernous sinus surgeries from my teacher, Dr. Krish. And actually, with accumulation of knowledge of anatomy around the cavernous sinus, more and more people actually explore this area. Once was recognized as a no man's area. But like Professor Schott mentioned, actually the anatomy of the cavernous sinus is complex. These paracellular venous channels actually as close related to the skull-based bony structures and dural structures with critical neurovascular structures penetrating through. So like this picture shows every critical cranial nerves and the artery penetrating the dura and into the cavernous sinus. So it's like a box. And also there is some important cranial like cranial 6 as go within the box, and some other cranial nerves are overlying the wall of the box. But how the topic of my talk is how to turn the anatomy work into your daily routine. We did a lot of work in the lab. We memorized the term of anatomy, but most of the people, they don't know what's the importance of these landmarks, which can be applied to your daily routine. So this is my topic of my talk. When I back to Taipei, based on what I learned from my teachers and based on my experience gathering in the last 10 years, I have my concept and I categorize the techniques of cavernous sinus surgeries. So in these slides, like Dr. Shah mentioned, the cavernous sinus anatomy, you can categorize into 4 parts, like dural structures, bony structures, venous channels, and neurovascular structures. Each structures, there is some important landmarks which you have to memorize. You have to know how to apply to your daily surgeries. For example, you have to know how to deal with the dura propria. You know that there's 2 layers, the dura overlying the lateral wall of the cavernous sinus. And you have to know how to deal with the outer ring and the inner ring. And also for the bony structures, the most important is you have to know how to remove the anterior clinoid. And also you have to know all the cranial nerves, which direction and which what is anchored to the dura structure. You have to release all these cranial nerves from all these the dura structures. So in this slide, on the most right side column, if you do the cavernous sinus surgery, it's like building blocks. So you can see the block area. It's the basic approach of the cavernous sinus. It means that you have to be equipped with the basic techniques. So you have to know how to peel in the dura off the cavernous sinus. you have to know how to do the anterior clinoidectomy, and also you have to be familiar with the dural ring removal. So this is the basics of the cavernous sinus surgery. Then with extending based on the different location of pathology and size of the pathologies, you can modify this basic approach, and based on your experience gathering, you can do the transmucoscape approach. Also, you can do the transcavernous approach. Or also, you can do the most complex, the transmucoscape, transentorial, and transmucoscape, transentorial, transpetrosal approach. So each approach actually specific to different parts of pathologies. Like maybe you can do the transmucoscape approach for the type A and type D peripheral trigeminal schwannoma. But most of the time, when you do the basic approach, you can do a lot of pathology, like a spinal ring, meningioma, tuberculous stellar meningioma, or intraorbital tumor, or most of the pecan aneurysm, paraclinal aneurysm. And also, if you are equipped the most advanced techniques, you're familiar with all the anatomy surrounding the cavernous sinus, then you can deal with the most complex one, like the brainstem lesions or the petroclival meningioma. So I categorize the learning curve in cavernous sinus surgeries. If you are a beginner, you are at level 1, maybe you start with the tuberculous stellar meningioma or spinal ridge meningioma, and you have to do the Simpson grade 1 resection. And also you have to deal with the ophthalmic or pecan aneurysms. But you have the more advances, like you playing the video games, you get the new weapons, or you learn the new techniques, you level up. So when you're at level 2, now you can deal with the clinodal meningioma, or you can deal with the more complex paraclinal aneurysm like medial ventral projecting aneurysms, or you can deal with the craniopharyngioma and also the type A and D schwannoma. And the most top of the level, the most difficult one, I think, is petroclival meningiomas, cavernous sinus meningioma, or chordoma. So different level, that means that you have the different techniques. So the level 1, like I said, you have to know how to peel the dura off the lateral wall of the cavernous sinus. You have to know how to do the anterior clinoidectomy, and also you have to deal with the dorsal ring removal and opening the optic nerve, mobilize the carotid. And at the level 4, the top level, you have to open every windows within the cavernous sinus, and also you have to do the anterior petrosectomy, mobilized in the trochlear trigeminal nerve, and also you have to localize the 6th nerve within the dural canals. So the most critical concept and techniques of cavernous sinus surgery I have to simplify it is the essence of the surgery is unlocking it. What I said, unlocking it. Like my teacher, Dr. Krish, always said, unlocking the cavernous sinus. And years later, I realized what it means, because like we said, all the critical cranial nerves and arteries that penetrate through the dura into the jewelry box. So like you open the box, you have to like untie the ribbon surrounding the box. So for the cavernous sinus surgery, the first step is peeling off the dura of the lateral wall cavernous sinus, because in this way, you make the detailed anatomy shallow. If it becomes shallow, and it facilitates your maneuverability surrounding the box. Then the second way, you have to remove the bony structures, the bony blocks in the way to your view, like an anterior clinoid. You have to remove the anterior clinoid to expose the sella and suprasellar region. And also you have to free all the nerves from where it is anchored to the dura, so that you can lessen and minimize the injury to the nerve And also you can widen the window between each nerve or muscular structures.
Mhm.
So I learned from Dr. Krish. So I do almost every case in pretemporal approach. It means that when you dissect the temporalis muscle, you have to cut the muscle down to the zygomatic notch, and more lower than the traditional pterional approach. But if you want to do the more advanced exposure of the lateral of the cavernous sinus, sometimes you have to just remove the zygoma. Actually, I don't do the OZ or COZ approach. I just cut the zygoma arch and attach to the temporalis muscle, and no one has the cosmetic problem after surgery. So like Professor Shah mentioned, we have two layers of dura overlying the lateral wall of the cavernous sinus. And actually, I always describe the dura like a shirt with two shoulder straps attached to the lateral wall of the cavernous sinus. One shoulder strap is meningo-orbital artery is within the dura fold. Another shoulder strap is the middle meningeal artery and also with the dura fold. And with these two dura folds, the temporal dura is attached to the lateral wall of the cavernous sinus. And you can always find the dura group just below the superior orbital fissure. So when you start the peeling off the dura, you have to find the superior orbital fissure. You can always find the dura groove just below that. And usually we do the sharp dissection just precisely into the two layers of the dura. Just keep the cleavage plane. And sometimes you use the blunt dissection and you push the dura backward to expose the trochlear nerve, the V1 and V2, and also the anterior clinoids. So this is well known and described by Dolank, Professor Dolank. If you want to do the advanced exposure of the cavernous sinus, then you turn your microscope to the middle meningeal artery. You find it, then coagulate and cut it. Then you expose the V3. Then you push the dura backwards and be careful to preserve the GSPN so that you push the dura anterior to posteriorly, not perpendicular to the GSPN, so that you will injure the GSPN. So you preserve the GSPN, then you can expose the quasi triangle. Now you can fully expose the lateral wall of the cavernous sinus. So this is the foundation and the basic steps for you to do the cavernous sinus surgery. Since you have do the epidural work and you gain a lot of space outside the dura, so if you want to cut the dura, this is reasonable to just cut the dura along the sylvian fissure down to the base of the dura, then extend the incision bilaterally. So you cut the dura along the sylvian fissure down to the base, then extend it bilaterally to expose the carotid artery and the optic nerve. And when you do the peeling off the dura, and most of people always ask how to do the hemostasis because it's always whizzing from each windows of the cavernous sinus. So you have to know the venous anatomy surrounding the cavernous sinus. It's complex, but it's a lot of collateral channels within the cavernous sinus and out of the cavernous sinus. So I learned from the techniques from Dr. Krish. I do the hemostasis using the T-seal. And you can push the T-seal into every windows within the cavernous sinus. But when you push in the T-seal, remember just press using your sucker to press the sphenoparietal vein to preventing the glue backwards to flow into the sylvian vein. Otherwise, you are causing the post-op brain swelling. And never inject the glue into the superior pituitary sinus. Otherwise, you will cause catastrophe because maybe you compromise the flow to the transverse sinus and sigmoid sinus, then you will be terrified. Something terrified will happen. And remember preserving the deep Sylvian vein, because when you push the seal, it may transiently it occupies the venous channel, but if the deep Sylvian vein is kept patent, then you won't cause any venous infarction. So this picture shows you can just push the tissue into the windows between the V1 and V2, or just when you remove the clinoids, you can open the oculomotor membrane and inject the tissue into the membrane, because this space is also belongs to the cavernous sinus. Then you have to know the most important landmark is anterior clinode. If you know that the anterior clinodes have three attachments, the first one is sphinal ridge, the second one is optic canal and roof, the third one is optic strut, then you can remove the clinode efficiently. So the first step, usually I will drill the sphinal ridge, I will remove the little wall, the orbit. Then this step, I already detached the clinoids from the sphinal wing. Then you have to peeling the frontal dura to see where the optic nerve is. So you have an imaginary line along the optic roof. So the second step, you drill just overlying the optic roof and skeletonizing the optic nerve. Then you can weaken the clinodes, because most of the time the optic strut is fragile. So when you open the optic roof, actually the ACP, the clinode is mobilized. So you can easily to remove the clinoids step by step, if you know the three attachments of the clinoid to the skull bone. And like I said, every nerve and artery that penetrating the dura into the cavernous sinus. So this picture showed the real surgery. You can see the carotids, the optic nerve, and the oculomotor nerve. They all are penetrating the dura into the cavernous sinus. So when you do the cavernous sinus surgery, it is very important. Just free all these critical neurovascular structure from the dura. So you have to remove the ring or ring-like structures surrounding these structures. For example, like Professor Shah mentioned, there's a phospholigament overlying the optic nerve, and also the artery overlying the carotids. So you have to remove the phospholigament or the ring to free the optic nerve and the carotids, so that you can mobilize the nerve or mobilize the carotid to widen the carotical optical window. So like this picture show, if you remove the ring structure or the phospholigament, then you expose the window between the carotid and optic nerve, you can find the ophthalmic artery, and this is the basic step for you to deal with the paraclinal aneurysm. Also, if you remove all the ring-like structures surrounding all these nerve or vessels, you can expose the whole little wall or the roof. You can open the roof or the cavernous sinus. So this picture show you actually expose the whole segment of the carotid. You can see the distal carotid, the siphon, and the proximal intracavernous segment of the carotids, because you already free the oculomotor nerve, and you can mobilize the nerve to expose the roof or the cavernous sinus. So like I mentioned, I did different approach of the cavernous sinus and categorized into 4 levels. So the level 1 and level 2, this is the basic approach. And actually we're focusing on the pathology surrounding the cellular, supracellular, interpeduncular fossa. Like this one. This is the simple case. This is the sphenoid meningioma lateral type. I think this is the level 1 because the only technique you need to know is just the dura peeling. You do the extradural peeling. Then you expose the lateral the cavernous sinus and actually already devascularize the blood supplies to the tumor. Why? Because in these pictures, I do the extradural dissection. I didn't see the tumor because the tumor is within the dura. But when you do the extradural peeling, the blood supply is already gone. So when you do the intradural part, you will find there's almost no blood loss from if you do the tumor removal. So you do the extradural peeling, then you cut the dura along the cilium fissure down to the base of the dura. At this stage, you still didn't see the tumor. But now you can cut the dura surrounding the tumor margin. So you cut the dura around the tumor margin. Since you already devascularized from the base of the dura, and you already exposed the base of the dura. So you cut the dura surrounding the tumor is very easy. So you can remove the tumor en bloc. Then this is the post-op picture. So you remove the tumor as long as the dura, you achieve the Simpson grade 1 recession. So this is the simplest case. For the beginner, you have to start with the lateral type, the sphenoid meningioma, because the only one technique you have to know is dura peeling. Then you have familiar with this technique. Now you have to do the anterior clinoidectomy. You have to know how to remove the phospholipid and outer ring. So you can do the tuberculous cellular meningioma like this one. When you remove the anterior clino, like I say, you remove the blocks in the view to the cellular and the supracellular region. Then you remove the clino, also facilitating to expose the outer ring so that you can remove the ring surrounding the carotids, and also you can remove the phospholipid surrounding the optic nerve, especially for the tuberculous cellular meningioma. At the beginning, at the first step, you have to remove these ring structures because in this picture, you can see when you remove the phospholipid, then you can see the indentation like an arrow showed, the indentation overlying the optic nerve. So if you don't remove the ring, then you start to remove the tumor, you mobilize, you push the optic nerve, then the nerve is against the ring, then you will cause much of the injury to the ring related to the traction. So if you release, free the nerve from the ring, then you mobilize the nerve and you widen the window so you can remove the tumor. So this is the very important concept for the tuberculous cellular meningioma. And the second simplest case is the pica aneurysm. You just do the dura peeling, remove the anterior clinoid, and just remove the dorsal side of the outer ring, expose the carotids. In this trajectory of the view, actually you can see the aneurysm and also the takeoff of the pecan. I like this approach rather than the transylvian, because if you do the transylvian approach, the trajectory of the view is to the carotids, is to the dorsal aspect of carotid, not the lateral aspect of the carotid. So if the view is to the dorsal aspect of carotid, sometimes it's difficult to see the takeoff of the pecan. So if you can see the takeoff of the pecan, when you put the first clip or put a permanent clip, you can avoid to catch the pecan. So this is very important. So this trajectory is very good for the pica aneurysm if you know how to do the basic approach of the cavernous sinus. Then you can do the simple case of the paraglandular aneurysm like ophthalmic aneurysm. Because this aneurysm is projecting dorsally, you just do the dura peeling, anterior clinoidectomy, and just remove the dorsal ring. Then you can expose the whole segment of the aneurysm, and the clipping just the simplest step of the aneurysm clipping. So like this picture showed, you remove the anticlinoid, you open the dura, then you remove the ring overlying the carotids or the aneurysm. Then you can expose the whole segment of the aneurysm. And also, if you remove the clinoid, you have the space for the proximal control. Then you can put a clip to catch the aneurysm easily. And also like this case, like I mentioned, I always open the lateral wall of the cabin, the lateral orbital wall, find the severe orbital fissure, do the extradural pilling, like standard steps to remove the anticlinoid, cut the dura. I open the phospholipid to expose the optic nerve, and also I remove the outer ring overlying the aneurysm. So you have to be very meticulously to remove the ring structure of the aneurysm. If you didn't remove the ring very well, if you put the clip will catch the aneurysm and the ring. Sometimes the ring, if you catch the ring, you will strangulate the carotid and causing the compromise of the flow. So this is very important. You have to remove the ring totally off the carotid and the aneurysm, and then don't cause the sling effect. Otherwise, if you put a clip, you catch the ring as well, and sometimes you found you compromise the flow of the carotid. So in this case, I put a pilot clip, then remove the ring well, then put the permanent clip. So this is the simple case. If you know how to do the anterior clinoidectomy and remove the ring. But sometimes you have to deal with the complex peritoneal aneurysm. So except for the dural peeling, anterior clinoidectomy, other ring removal, actually for the different projection in aneurysm, like a medial inferior projection aneurysm, you have to circumcision. You have to know how to circumcise the ring totally of the carotid. Like this case, I would like to show. This is, I remove the clinoids and also the dorsal aspect of the outer ring. Now I remove the dorsal aspect of outer ring to free the carotid from the ring. And usually, if the aneurysm is medially or inferiorly projected, you can see this is a medial projecting aneurysm, and you can see the ophthalmic aneurysm, the ophthalmic artery. So most of this case, you have to put a fenestrating clip. But if you don't remove the ring totally, usually the outer ring attached to the optic strut. If you didn't remove the ring off the strut, you cannot advance clips to catch the whole segment in the neck. So you have to cut the ring off the optic struts, and you have to see the medial aspect of carotid and even the proximal neck or the aneurysm. So you can see the tip didn't catch the whole segment of the neck. So you have to remove the ring totally on the medial aspect of the carotid. Then you free the ophthalmic artery, you see the proximal neck of the aneurysm. Now you can advance your clip to catch the whole segment of the neck. So now you can totally occlude the aneurysm. And sometimes you are facing the complex large carotid aneurysm. So the additional techniques is how to do with the proximal control. Most of the people, they are concerned about the proximal control. They may open the neck carotid, or maybe they can do the petrosectomy to expose the petrosal carotid. But I will show you the simplest way if you know how to open the cavernous sinus. Usually I prepare the space in Parkinson triangle for the proximal control. Like this case is a huge pecan aneurysm. When I opened the dura and I realized the carotid is severely calcified, I cannot put any plasma in the carotid. So I need another space for plasma control. So I opened the space between the force and V1, so-called Parkinson triangle, to localize the carotid artery. So now I have the plasma control. Then I put the plasma control and this control on A1 to just decrease the flow into the aneurysm, to weaken the tension of the aneurysm, and I'm using the coagulation to shrinking the aneurysm to make it smaller. Now using the clip shaping the aneurysm, now I can see the whole segment of P-con to the P1 and P2 to make sure I didn't compromise any important arteries, and check with the Doppler. And so this case, I just show if you have no space for proximal control in inclinal space, the Parkinson triangle, you have to always prepare for the proximal control. This is another case. It's a large intracavernous aneurysm. The patient presenting with the double vision. So I peeling off the dura, exposed the lateral wall of the cavernous sinus, and I opened the Parkinson triangle to localize the carotid. And you can see this is the sixth nerve. This is aneurysm. And the oculomotor nerve is overlying the aneurysm so that the patient has double vision. So you can see, now I have the proximal control in Parkinson triangle, so I can shrinking the aneurysm and put a pilot clip. But I didn't catch the whole segment of the neck, so I'll shrink down the aneurysm, then a premature rupture. But since I have the proximal control, I just put a clip and lessen the bleeding, and then I have time to do the clipping. When I do the clip, now I open the dura. Why? Because if you cause the bleeding from the aneurysm before opening the dura, then all the bleeding will not gush into the brain. So when I secure the aneurysm, now I open the dura to make sure that I catch the whole aneurysm. So this is another case that I show you how to open the Parkinson triangle to make the proximal control. And also the craniopharyngioma. You did the similar techniques, but now you have to open the Sylvian fissure to elevate the frontal lobe, like this one, or this one. And this is the intraoperative picture. If you remove the clinoids, if you remove the whole ring surrounding the carotid and the phospholamina surrounding the optic nerve, you can widen the space into the between the optic nerve and the carotid, and you open the sylvian so that you can elevate the frontal to expose the opposite side of the optic nerve. So you can show the pituitary stalk below the optic nerve through this window. And also, when you remove the tumor, you can see the pituitary stalk. You mobilize the optic nerve. You can either see the carotid in the opposite side. So this approach is very good for the craniopharyngioma. And like Professor Sham showed the case, the level 2 techniques, you can deal with the clinomeningioma. It's similar to the spinal wing meningioma, but the difference is you have to open the sylvian, you follow the N1 segment into the tumor. Because the clinomeningioma, the tumor always encasing the carotid, but you have to follow the sylvian, follow the M1. Then you remove the clinoid, you can follow the proximal carotid and follow the distal carotid. Then within the tumor, you can preserve the carotid. This is more safe to do the clinomeningioma. So this is a similar case as Professor Shah showed. Now, If you have all these techniques and if you know how to totally expose the cavernous sinus, then this is very easy for you to deal with the lesion within the Makel's cave, because the roof of the Makel's cave is very thin. You just open the Makel's cave, you can expose the Gazerian ganglion and the trigeminal nerve. So for most of the trigeminal schwannoma, I just do the extradural peeling and opening the Makel's cave. And sometimes I cut the temporal base dura, expose the tentorium, and I cut the tentorium to widen the aperture of the Makel's cave. So like this case is the type A or type D is very simple if you know how to do the extradural peeling and open the Makel's cave. So this picture shows that I do the extradural peeling, and actually the tumor is bulging from the Makel's cave. And you open the Makel's cave, remove the debulk the tumor, and you can always find the nerve fibers overlying the tumor. So be careful, you remove the tumor and preserve the most of the trigeminal nerve fibers. So if you know how to open the Makel's cave, and if you know how to cut the tentorium, now you can deal with the pathology surrounding the sella, suprasella, interpeduncular, and additional the preponding space. So this case showed you do the extradural exposure, expose the Makel's cave and Gazerian ganglion. Then you cut the temporal base dura, expose the tentorium, and you cut the tentorium, you can follow the whole segment of the trigeminal nerve down to the preponding space, down to its brainstem. So from this approach, actually following the axis of trigeminal nerve, you can deal with every type of the trigeminal schwannoma and also the lesion in the pons. So like this case, this is a type B and type C. The dumbbell type or the posterior fossa type of the schwannoma is very easy. You open the Makel's cave and open the tentorium following the tumor down to the brainstem. Like this case, you open the Makel's cave and you debulk the tumor and you found the nerve fibers, and following the nerve fibers down to the brainstem. So this is post-op. So this is very easy to remove the trigeminal schwannoma if you know how to do it. And for all these post-op MRI, you can see we all preserve the trigeminal nerve, like you see in the post-op MRI. So if you equip more advanced techniques, so now you are at a level 3. At the level 3, you can deal with more complex pathology, like this one. This is the basilar apex aneurysm. To deal with the basilar apex aneurysm, the additional techniques is you have to open the oculomotor window. You have to free the oculomotor nerve so that you can widen the space to mobilize the oculomotor laterally. You can widen the space into the preponding fossa, facilitating to put the proximal control. Also, you have to remove the PCP if it's prominent, it's in the way to your proximal control. So you have to mobilize the oculomotor nerve, you have to remove the PCP, and also you have to open the sylvium. So in this case, it's a basilar apex. You can see I free the whole segment of the oculomotor from the oculomotor membrane, so I can mobilize the third nerve. If you can mobilize the third nerve, then you can remove the PCP. It's more safe to do to remove the PCP using the bony QSAR, but without the bony QSAR, you have to be careful just using the drill, diamond drill, and be careful, don't put any cotton surrounding your surgical field, otherwise you caught, the drill will catch the cotton and injure all the tissue surroundings. So you mobilize the third nerve, you remove the PCP, then you can expose the adequate segment of the basilar trunk and expose the bilateral both sides of the SCA and the PCA. So now you have the space for the proximal control. Then you can use to shrink aneurysm. Then the permanent clip is the simplest step of the aneurysm clipping. Also, if it depends on the aneurysm, sometimes is a high lying or low lying. If the aneurysm is low lying, you have to cut the tentorium to get more space for the proximal control. Like this one, it is very large, sometimes something like a fusiform aneurysm. And as usual, I do the extradural peeling. I cut a meningoorbital fissure, dural fold, do the extradural peeling just beginning below the superior orbital fissure, peeling off the dura and just inject the TCO between the V1 and V2 and keep peeling the dura back off and expose the ICP and remove the ICP. Then I cut the dura down to the base and extend the dura excision bilaterally to remove the outer ring so that I can mobilize the carotids to widen the window. And I have to open the sylvian to expose the whole segment of the carotid. Now I free the oculomotor nerve from the oculomotor triangle and free the oculomotor and expose the PCP. I remove the PCP so that I had a window to access to the proximal basilar trunk so that I had the proximal control. Using coagulation to shrink down the aneurysm. And I using the clip shaping technique. Just shaping the aneurysm to make it, using the coagulation, make it smaller and make the shaping easier. And just watch every perforators of the basilar apex and trunk. So this is a post-op, and you can see there's no infarction in the brainstem from the post-op MRI. Also, if you at the level 3, now you have qualifies to deal with the invasive macroadenoma. For the macroadenoma, you have to know how the growth pattern of the adenoma. Sometimes is the growth superiorly and into the supracellular region. They're growing backwards into the oculomotor window, even down below the hippocampus, below the tentorium. And also they can come down in the infratemporal fossa, like Professor Shah mentioned. So this animation shows the tumor growth pattern. They grow superiorly into the superior cellular region and backward into the oculomotor triangle and downward maybe into the infratemporal fossa. So from the MRI, you can see this tumor is within the cavernous sinus. Then it grows laterally and backwards and within the oculomotor window, but also downwards into the infratemporal fossa. So if you know the growth pattern of the macroadenoma, so now you know the most important thing is if the tumor is dense, then the nerve are stretched at the anchor, where the anchor to the dura. So when you deal with the huge invasive pituitary macroadenoma, remember you have to release all the nerves step by step, all the nerves from the dura. Otherwise, because you remove the tumor between each window between each nerves, If you free all these nerve, then you can widen the window and lessen the injury to the nerve. So like this case, at the beginning, usually the clinoid already eroded by the tumors. It's very easy to remove the clinoid. If you remove the clinoid, sometimes the tumor is gushing out by the pressure. So you remove a little bit tumor to expose the carotid within the clinoid portion. Then you mobilize the third nerve. You open the roof into the of the cavernous sinus. Then you can open the window between the third nerve and the trochlear nerve to remove the tumor and expose the intracavernous carotids. And now, then you move the microscope to the Parkinson triangle. You open the Parkinson triangle, remove the tumor, also follow the carotids. And at this stage, you have to localize the sixth nerve. Now you move the next step is between the V2 and V3. Then you can remove the tumors in the suprasellar region. You expose the whole segment of carotid, like I mentioned in the case of craniopharyngioma. You mobilize the carotids, you mobilize the optic nerve to remove the tumor in the suprasellar region. And also, you can remove the tumor down to the diaphragm sella, down to the sellar region. And this is the post-op picture. As you can see, I delineate each cranial nerve. I free all these nerves from the dura, and also I remove the tumor following the carotid. So this is the key steps when you're dealing with the invasive pituitary microadenoma. Now, if you are really familiar with all these techniques surrounding the cavernous sinus, now you are equipped with the most advanced techniques. You are now at the level 4. At the level 4, you have to know how to remove the petrous bone. Then you can open the space into the posterior fossa. If you totally do all the steps, you can deal with the large pathologies extending from the suprasellar, sellar, preponding space, and down to the posterior fossa, like the petroclival meningioma. As you know, the petroclival meningioma sitting medial to the IAC and posterior to a Gasserian ganglion. The large petroclival meningioma could be occupied the suprasellar, interpeduncular, and preponding space. So this kind of the lesion, actually the transcavernous approach, I think is the best approach for petroclival meningioma. And when you deal with the petroclival meningioma, we have 3 major obstacles to the view. The first one is the anterior clinal process, because you have to remove the anterior clinal processes to access to the sellar and suprasellar region. The second obstacle is the tentorian and posterior clinoid. If you incise, divide the tentorian, if you remove the posterior clinoid, like I mentioned, you can open the space to the interpeduncular and preponding space. And the third obstacle is the anterior petrous. If you remove the anterior petrous, then you can open the dura and then you can expose the space in the posterior fossa. Even you can expose the IAC to localize the 7 and 8 nerves. So this picture shows 3 obstacles in different trajectory to deal with the petroclival meningioma. So it's very complex when you do the petroclival meningioma, but you have to know the step by step. You have to remove the first obstacles. You have to free the carotid, the optic nerve. Then you have to remove the second obstacles. You have to open the macroscape, dividing the tentorium, remove the PCP. You can mobilize the trigenium nerve. You can cut the gruber ligament to localize the 6th nerve. Then you remove the third obstacles. You remove the anterior petrous. Then you can remove the tumor down to the posterior fossa. So like this case, the first step, I do the extradural peeling, then totally expose the lateral wall of the cavernous sinus. And I remove the ICP. I remove the first obstacles of the view to the petroclival region. I open the dura, and also I open the macroscaphe. Then the second stage is I do the anterior petrosectomy. As you see, I open the macroscaphe, then I cut the tentorium down to the posterior fossa. So as you see, I follow the trigeminal nerve into the posterior fossa because I already removed the anterior petrous parts. And now you can mobilize the trigeminal nerve to see the round and to localize the sixth nerve. And you can do, if you prepare everything, now the tumor removal is efficiently within short time. And this is this post-op picture. Most of the people are actually, they has a transient neurological deficit for the eye movements. But in Taiwan, in Taipei, we have very good Chinese medicine. So I always send the patient, refer the patient for acupuncture. So usually within 6 months, if the nerves is intact, usually within 6 months, they totally recover the post-op neurological deficit. So this is case, and also this case, all do the transcavernous approach. So this video showed how we, sorry. Sorry, I don't know why, what happened.
This is a 30-year-old female with unsteady gait, dysphagia, and dysarthria. MRI showed a giant petroclival tumor.
This case we
severe
published in
compression.
Neurosurgical Focus.
The tumor
It's a
bulged
large
upward, compressing the third
petroclival
ventricle,
tumor.
extended down to the lower clivus, pushed pituitary stalk and ICA anteriorly. It involved Michael's cave and basilar artery. Under general anesthesia, the patient was in supine position. The head was fixed by Mayfield head holder. A curvilinear skin incision was made over the frontal temporal region. A standard perioral craniotomy along with zygoma fracture was performed. Additional bone drilling was carried out down to the temporal base. Flattened the sphenoid wing and exposed the periorbita. Cut the meningo-orbital fold. Open the superior orbital fissure. Peel the lateral wall of the cavernous sinus. Inject tissue glue between V1 and V2 for hemostasis.
And I remove the pictures.
Coagulate and cut the middle meningeal artery. Expose V3 and GSPA. Perform the anterior petrosectomy. Check the location for petrous ICA. Remove ACP extradurally. Drill the optic strut and remove ACP. Finish the extradural bony work.
So if we prepare everything,
This is the surgical view of transmechos cave transtentorial approach in this case. We cut the dura from ACP tip to petrous apex. A T-shaped durotomy.
if you prepare everything, then tumor removal will become simple and more efficiently within short time. Then you step by step to free all the nerves from the optic nerve down to the
approach. Dura propria was peeled to the
trigeminal.
edge of incisura. The dura was cut along the green dots. Use CUSA to debulk the tumor.
As you see, I free
Cut
the optic
pulsing
nerve, then
ligament and
free
distal dura
the
ring for ICA mobilization.
oculomotor nerve. and also free the carotids to mobilize all these structures to facilitate the tumor removal.
Dissect the superior surface of the tumor away from the third ventricular floor. Expose the ACA and MCA. Continue debulking. Dissect tumor from the space created by anterior petrosectomy.
You see, if you mobilize the trigeminal,
Remove
you
the
can
tumor
localize the
invading
sixth
Meckel's
nerve
cave.
and also remove the tumor within the Meckel's cave.
Cut the tumor base.
And you cut the tumor just behind the Goel ligament is safe
Dissect the tumor from the brain stem.
because the sixth nerve is within the Goel ligament. So if
Dissect
you,
around the tumor. And finally, remove it.
so as you see, you can expose very wide space into the suprasellar, sellar, prepontine, interpeduncular, and posterior fossa. Now I close the dura, and for the dura defect, I always put the fat and overline by some like dura, the hemopatch, and seal with the glue. Another case, I just want to show, this is the same steps. I just want to show, as I mentioned, you remove the tumor behind the Goel ligament, then you open the space between the V1 and the tracheal nerve. You can always localize the six nerves within the dural canals. So this is another case which I show how I localize the sixth nerve. And this is a post-op MRI.
Pretemporal transcavernous
Also,
transtentorial
with this
approach for right
techniques, you can
cavernous
also
malformation. This is a
deal with the
57-year-old
brainstem
man with
lesion, like this
progressive
case.
headaches, nausea, vomiting, drowsiness, and unsteady gait for 5 days. The brain CT showed a heterogeneous high-density lesion at the right aspect of the pons. The MR study was compatible with a cavernous malformation with recent intralesional hemorrhage at right side pons. The corticospinal tracts were pushed backward by the cavernous malformation.
So as I showed, if you open the space to the pons lesion by my techniques, you can deal with such a lesion within the pons. And this animation shows the lesion related to the structures of the cavernous sinus. I can choose the good corridor to this lesion.
Under general anesthesia, the patient was in supine position. The head was fixed by Mayfield head holder. A standard pterional craniotomy was performed with zygoma fracture. Flatten the sphenoid wing. Expose the periorbita. Peel the lateral wall of the cavernous sinus.
Yeah, most of the time I using the sharp dissection.
Inject tissue glues for hemostasis. Remove the ACP extradurally.
sometimes the ACP is pneumatized, so be careful. You have to put a little bit muscle in prevent of
Open the
CSF
Mecos
leakage.
cave. Cut the dura along the tentorium horizontally.
You open the Mecos cave, then you expose the tentorium.
Open the liquid membrane.
Now you can divide the tentorium to widely expose the preponding space.
Expose the fourth nerve. A vertical cut at the tentorium. Connect the vertical and horizontal cuts to release the tentorium.
I learned these techniques as
Intraoperative neural
fixed the
monitoring,
tentorium
subcortical motor tract
by
mapping.
Professor Johan.
A small cortical incision was made.
Now you choose the safety zone into the lesion, and actually the removal lesion is become the simplest steps of the whole surgery.
Sanford, in the interest of time, if you don't mind,
Okay.
could we wrap up after this? Please finish this. And if you have any other important points to make, and then we'll try one or two questions, if that's okay.
I think this is the last case.
Right.
So
For cavernous malformation located at.
So I would like to thank you all because I have a chance to introduce my experience in the cavernous sinus surgery. And also I have to thank my great teachers, Professor Dr. Krishit and Professor Amarty and Professor Yasakil, and also our good friends, Professor Evangel and Dolank. I learned a lot from them. And it's my honor to join their world. And I also enjoying all their experience and techniques. And in Taipei, in my department, we had 5 different topics of the dissection course in my department, and all of you are welcome. But because the COVID-19, so some of the courses are postponed next year. And also we are welcome to international fellows to my department because we provide free lunch and dinner during weekdays and also very cheap accommodations. And welcome. And also thank you, everyone. Thank you.
Sanford, thank you very much. That was a very, very impressive talk. Some very advanced operations demonstrated there. I think it built very nicely from what we heard from our previous speaker, where we looked at the anatomy in great detail, very beautifully, and then you had a very nice system for people to progress through the steps. And I think that's an important point to make. We've got almost 200 people at least watching, maybe more. And I think that's quite an important point to make, that these are advanced techniques and you have to build up to it slowly. I'm sure you would agree, Sanford. Would that be a fair comment to make?
Yeah.
So these are things that you can try and work through the levels. These videos are going to be on YouTube. You can watch them, look at the anatomy carefully. I wouldn't attempt any of these things unless you understood the anatomy well, and then you can work through the levels. Going back to my point that some of the people here watching may be less advanced, and you sort of touched upon this, And while I look for a question from our audience, would you mind just explaining to everyone present here, when you're cutting the distal dural ring and its relationship to the adventitia of the carotid, you spent a lot of time early on talking about cutting the distal dural ring. And could you just talk us through its relationship to the adventitia of the carotid and how when people are starting to do this procedure, what important anatomy they need to understand so they don't injure into the carotid?
And I think this is a very good question, because I did mention in my talk that when I remove the outer ring, actually there's small techniques. When you remove the clinoid, you have to notify there's always the membrane surrounding the carotid. It's the extension of the oculomotor membrane. So usually I can cut the membrane in the clinal portion, so I can inject the tissue within this membrane. And this membrane guides you to remove the outer ring. I cut the ring. I have to open the membrane to really localize the wall of the carotid. Then if you cut the ring, I always use the blunt tipped scissor. So I cut the ring along the carotid only after I open the membrane. Do you what I mean? Because the oculomotor membrane, the extension of oculomotor membrane covering the clinal portion of the carotid and fused with the outer ring. So you have to open the membrane. It means that you free the both sides of the ring so that you cut the ring, you can visualize the ring, the relation to the carotid. Yeah.
And Sanford, also, you had a very nice picture in one of your early bits. The ring merges with the adventitia of the carotid, doesn't it? And so you have to cut it round as a ring. So people, when they start to do this, sometimes they cut towards the carotid and can very easily injure the carotid. You had a beautiful picture, I think, demonstrating that, right? Just probably an important point to highlight how the distal dural ring fuses with the adventitia of the carotid. Would you agree with that?
Yeah, sure.
And so that's a very important thing. Now I've got a question from, and then we'll move on to Professor Goel, but from Harshad Parekh, who's asking, would you remove or drill the anterior clinoid extradurally or intradurally for clipping of aneurysm? So I think the question here is, a lot of people indifferent to skull-base tumors for aneurysms advocate drilling intradurally. Now you're a very experienced surgeon, obviously. What would you advise people who are, well, both for yourself and starting out, what would you advise them?
Yes, actually these questions, I saw a lot of debates from Dr. Christian de Oliveira. Dr. Krish prefers extradural clinoidectomy drilling, and de Oliveira likes intradural. But for me, of course, I think extradural drilling is the best because it don't cause a lot of the bony dust into the intradural space. Also, if you familiar with the anatomy, actually you see everything, even they are behind the dura. Actually, you see everything on your mind. So never mind that you didn't see the landmark of the structures. You see everything all of the dura. But extradural drilling is more safer than intradural drilling. If you saw the video from the one who do the intradural drilling surrounding the aneurysm, always looks terrible. So if you do the extradural drilling, actually there's a barrier they're protecting you from the aneurysm. So for me, I like extradural drilling because it's more safer and actually it won't cause any bony dust into the intradural space.
Thank you. So there you've heard a view there. And I think I have to emphasize again that Professor Sanford is a very experienced neurosurgeon showing some very advanced techniques, and you have to understand what your own skill and anatomy level is. You're going to see another talk now, which is going to show also, I'm sure, very advanced operations. And so we should all work to an appropriate level. Professor Sanford, thank you very much. Fantastic talk. Very impressive. Thank you very much.
Thank you.
Make a quick comment, Abida. There was a question from Ike Cherian, who was so impressed by your presentation. He'd like you to present, so if you could answer Ike. There's a question out there. So it's nice to see Ike Cherian join us, another very good, fantastic cavernous sinus surgeon. Now I'm going to have to do something that's even harder than operating on the cavernous sinus, and that is to try and summarize Professor Goel's extensive experience. So this is even harder than trying to operate the cavernous sinus. Atul, I hope I'm going to miss a lot of things out. I hope you'll forgive me. Now, Professor Goel, of course, is the professor and head of department at the King Edward Memorial Hospital and Seth GS Medical College. He's a consultant at the Tata Memorial Hospital and Cancer Research Institute. He's the editor-in-chief of multiple journals. He's got over 650 publications. But I think more importantly, he is a very, very experienced neurosurgeon who has published some landmark papers for key aspects of neurosurgery, including the cavernous sinus. He really understands the technique, the anatomy. He's published a lot of the work that we've all read. So it's a real pleasure to introduce Atul. I'm sure he'll give us an absolutely fantastic lecture of his huge experience. Atul, thank you for joining us.
Thank you, Sanjeeva. And it is my great pleasure and great honor to be a part of this show. And for next 90 minutes, fasten your seat belts and sit straight and sit tight. Cavernous sinus is really a complex issue. And I have spent a lifetime on cavernous sinus. And I must say, I have enjoyed this life in a very fascinating manner, difficult, but wonderful and beautiful. So what I am going to do for the next 90 minutes is to share with you my journey on this great subject of cavernous sinus. I must say that cavernous sinus surgery was born in the era of MRI. Before MRI, which was introduced in neurosurgery latter half of 1980s, cavernous sinus surgery was quite in a primitive fashion. But after MRI has been introduced, cavernous sinus surgery is really come into fore. As has been discussed, there is no question that we have to learn the anatomy, we have to understand the various intricacies of presence of dura, presence of nerves, and presence of carotid artery. It is not easy. It is not a game where you can do without doing any dissections. It is not a game without understanding the whole issue. It is a wonderful subject, and if you know it, you can actually give new life. So what I intend to do is, I want to show how cavernous sinus surgery can be done easily. This easily word is in inverted commas. In 1996, I wrote this book on cavernous sinus and on various complex tumors and vascular lesions. You can imagine in 1996, you see this dissection which is done here. The whole pityosectomy has been done. Carotid artery is mobilized, cavernous sinus, gasiran ganglion is mobilized, seventh nerve is mobilized, and you are seeing the entire view of petrous apex, clivus, and posterior cavernous sinus. So this was the way I worked during those times. Of course, I have certainly matured from this kind of dissection to a different world of cavernous sinus and skull base. So I want to show you. And I want to show you some philosophical issues. Alam al-Dimag is a word from Arabic legacy. And no one in the world of Arabic world or in any neurosurgical world has ever extracted this word from Arabic legacy. It means the meninges are the mother of brain. This is a very huge sentence in my own life and in my several articles that have been published on this subject. Dura is durable. This is the key word in my lifetime with neurosurgery, and I'm going to share this keyword on multiple occasions in my lecture. Dura is a very firm and compact membrane. There are no holes in the dura. It is like folded membrane. The nerves go never through the hole in the membrane. It goes along the membrane. and that I will also discuss. This compact dural membrane, this compact fort divides the spiritual brain, the most sterile organ of our body, from the outside world. It does not let any organisms in the paranasal sinus or in the oral mucosa even touch this beautiful brain. So this dura is a divine structure, and you must remember that whilst operating, we must respect the dura, because more importantly, the tumors respect the dura. And how the tumors respect the dura will be the subject of my lecture. During my journey of last 35 years with cavernous sinus, I have written several philosophical papers on this, on speculations about cavernous sinus, its role in eye movements and in eye health, maternalizing the cavernous sinus, ocularizing the cavernous sinus, and so on and so forth. I have discussed in my journey of last 35 years on cavernous sinus as to why the cavernous sinus is so intimately related to the pituitary gland, why the cavernous sinus is so intimately related to the sphenoid sinus, and why cavernous sinus is so intimately related to the internal carotid artery. Why the pituitary gland is neither intracranial nor extracranial is this location of pituitary gland, which is neither intracranial nor extracranial, in close vicinity to cavernous sinus and close vicinity to sphenoid sinus. Is this an anatomical error, or is it a functional necessity? So I will be discussing these things. So there are several articles of mine on philosophical issues of cavernous sinus, and I am putting those on the screen, and they will be on the YouTube, and you must go and watch. And if you have interest in this kind of speculations, you must read many of these articles. These are the only two articles in the history of neurosurgery which mention that there is some role of cavernous sinus. Cavernous sinus itself plays a role. These are the only two articles written in 1976. These articles mention that it has some role in cerebral blood flow and in heat maintenance of the body. Cavernous sinus plays a role. So these are the only two functions that cavernous sinus may be performing. So in these articles, I have written about what additional things cavernous sinus can be performing. So whatever nature does, even this fetal position has some role. It is, I call it, when there is a flight and you have some flight turbulence or something like that, the air hostess says, brace position. So this is the brace position of the fetus. So everything has a role to play. So there is nothing without any role. So this is the astronaut, and it is flying in the space. And this is the amnionaut. I call this fetus amnionaut, and it is floating in amniotic fluid. So if you ask me what is the role of amniotic fluid, it is most important role is to make the fetus weightless and let the pregnant lady do her function till the end of the fetal life. Similarly, if you ask me what is the function of CSF, it makes the brain weightless. It is such an important function of CSF, never described in the literature before, that CSF has major role in making the brain weightless. This is the brain, and it is floating in CSF. It makes the brain weightless. And brain is floating in CSF, does not touch the floor because of CSF and because of the blood in cavernous sinus. Both these things help to make the brain weightless. Of course, there are too many issues in this. I don't want to go in too much detail, but I will invite you to read many articles of mine where I have said the functions of fluid is to make the whole human body weightless and make it mobile. And when you run, it is on fluids. When you sit, it is on fluid. When you stand, it is on fluid. So I like to label cavernous sinus as a cavernous vena magna. So it is the largest venous plexus in the human body. And it has a great role in eye movements and protection of the eyeball. Eyeball is a hydrodynamic wonder of the body. If there is any excessive pressure on the eyeball in the vitreous humor and aqueous humor, which is a fluid-based hydrodynamic system, the lens is fluid-based, any pressure which is more than normal will not let it function. The lens will not be able to function, the retina will not be able to function, and the most noble organ cannot function if the hydrodynamic system of the eyeball is not functioning properly. And in my articles on the subject, I have said that the cavernous sinus has a great role to play in preserving the hydrodynamics of the eyeball. So there is this eyeball. Behind the eyeball is a non-compressible fat and a huge plexus of venous plexus behind the eyeball. And this relates the pressure to the cavernous sinus. The cavernous sinus, when the eye moves, it relates the movement to the cavernous sinus. So this is the eyeball. If you press the eyeball, the pressure goes behind and it relates to the contralateral eyeball through the intercavernous sinus. There is diplopia for some time and then the diplopia settles. So this intercavernous sinuses have a great role to play, and cavernous sinus has a great role to play. I like to label cavernous sinus as venous chiasma. So if you press on the eyeball, the thin retinal artery, which has no muscular layer, will immediately rupture. As soon as you press the eye, the retinal artery will rupture. It is because of the pressure transmission to the contralateral eye and to the cavernous sinus that the eyeball is able to sustain the function and to maintain the function. Imagine when the cavernous sinus gets thrombosed, there is no problem with the no problem with the nerves, but the whole eye movements are lost. In advanced stages, even the vision is lost. So in one of my beautiful articles on this subject, I said that the cavernous sinus has a role to play in eye movements and in the vision. Imagine when this gentleman lifts up such a heavy weight, the jugular vein is bloated, but nothing happens to the eyeball. I have said in my article that this cavernous sinus has the capacity to, as a sump or a neutralizing effect. So I like to label cavernous sinus as ocular Pascalian stability assuring system, or a sump and a venous lake which neutralizes the pressure. So this is the circle of Willis we have all seen, but we don't name, but we have seen a circle which I call as cavernous sinus. So cavernous sinus, without any doubt in your mind, you must know cavernous sinus has a great role in eye movement and in vision. Why the cavernous sinus in the deer is larger than the cavernous sinus in lion? This is my favorite slide, and I have shown it not less than 200 times in my various lectures. So when the deer runs, it looks in front, it looks behind, and the eyeball moves continuously in a very rapid manner so that it can run and jump, and simultaneously it can see the lion which is following and trying to hunt this and about to hit on the back and on the neck. So these eye movements are very rapid, and because rapid movements, the cavernous sinus is much bigger in a deer than in a lion which has to just look in front and jump and attack. It is not bothered about what is happening behind, or any mosquito or anything is coming to bite from behind. It has to just look in front. The line of vision is only 30 degrees in a lion, and in a deer it is 180 degrees. In a human body it is 70 degrees. This is the cavernous sinus of a monkey and a cavernous sinus of a human being. Cavernous sinus of a fish is much bigger. This Hakuba has said, and even the fat content in cavernous the swimming and also the balance and also the vision. So more the function of cavernous sinus, more the eye movements. Cavernous sinus lies behind the eye. What is beautiful is the eye, of course, but what lies behind the eye is more beautiful. And you see the eyes of several animals, and you see some beautiful eyes. The relationship of cavernous sinus with the sphenoid sinus. Sphenoid sinus, the nasal mucosa, the oral mucosa are the most vascular structures of the body. As soon as the air goes inside the nose, it is hot or cold in the nose, but as soon as it goes in the trachea, it is normal temperature. The temperature of the food, whether it is hot or cold, is hot in the mouth, but as soon as it goes in the mouth, beyond the mouth, it is normal temperature. Mucosa changes the temperature of these structures, and mucosa gives information to the cavernous sinus, to the carotid artery, to the pituitary gland, and this master gland regulates the whole body system. So this relationship has a great influence in the formation of the body and functioning of the body. One article by Vinco Dolenz that carotid artery goes in these turns, and these turns can make actually this kind of curvature can influence the temperature of the carotid artery and of the cavernous sinus. So cavernous itself makes the thing very strong. Cavernous, the plexus makes the venous plexus strong like this hand. Then there are several articles of mine that are based on anatomical information, extradural approach, which I described for the tumors for the first time in the literature. And there are several other articles which I will be discussing as we go further in our discussion. And there are several articles, most of the articles, I must say, are based on the dura and how the tumors respect the dura and how the surgeon should respect the dura during the operative endeavor. And if you respect the dura, if you understand the dural relationship, believe me, the whole world of cavernous sinus can be made rather simple and rather straightforward. And this is what I'm going to show you. I'm putting this list of these articles for you to have a list when you, if you have interest to go further in this subject. Membranes are the mother, and that forms the basis. So many of my articles are published before 95, before 92, 93, in those days when cavernous sinus surgery was not actually very popular and very few people in the world were doing cavernous sinus surgery. Of course, we know the work of Vinco Dolenz in the cavernous sinus, and he was the first one to show extradural approach to aneurysms and vascular lesions around the cavernous sinus, and also to trigeminal schwannomas extradural. So Vinco Dolenz work we respect, and he is my very good friend, and no question, he's my hero in cavernous sinus surgery. But what I'm going to show you is my work and my contributions to this subject and my several articles in the field of cavernous sinus. Most important is we must remember that the soft tissue is important. We must learn to respect the soft tissue in this fetus. There is not a spicule of bone. It is all soft tissue, and everything is there in this fetus, not a spicule of bone. Mandibular nerves goes into the foramen ovale. It is the mandibular nerve which is formed first. Foramen ovale comes later. mandibular nerve does not pass through foramen ovale. It is foramen ovale or the bone formation which comes afterwards. So bone is an afterthought in the nature. You must remember, bone is the weakest part of the human body. Membranes are the strongest part of the body. So my experience in 1993, I did this case. You can imagine 1993, during that time, nobody knew cavernous sinus, and this patient of mine is still alive after so many years of surgery. This is another tumor I did long time ago. This patient, beautiful operation in 1995, 25 years ago. This patient never came for follow-up. After 4 or 5 years, he used to come, but never afterwards. This is another anterior clinoid meningioma involving the cavernous sinus. Small residue, whether you will like to give radiation or not radiation, those issues have arisen or arrived in the horizons recently, but they were not such important issues during those times. This is another very memorable case of mine. One tumor behind the orbit, one tumor inside the cavernous sinus, and this patient was almost landing for removal of the eyeball when it landed to me, and very vascular tumor, so we removed the retroorbital tumor first, and then the cavernous sinus tumor. Both these tumors, this was hemangiopericytoma, this was a schwannoma. Both these tumors, complete removal and a very effective long-term outcome. So this patient is with me for 25 years now without any major symptom and without any recurrence. So cavernous sinus surgery has to be learned. It has to be effectively performed, and you have to make it look simple. So this is my article, which was published in the year 1997, which described extradural approach to tumors involving the cavernous sinus. This was the first article in Medline and in PubMed, intracavernous sinus tumors by an extradural operation, extradural approach. Learning and understanding the extradural approach and entering into the cavernous sinus, Vinko Dolenz, of course, did vascular lesions, and also he described this approach for trigeminal schwannomas, which I will go further and show my contributions in trigeminal schwannoma. So this article I wrote in 1998, which is heavily cited article in the literature, where I said cavernous sinus surgery, internal carotid artery relationship can determine the pathology of the tumor and your surgical strategy. Here the artery is squeezed by the tumor. Here artery is encased but not squeezed by the tumor. Here the artery is displaced by the tumor. And these relationships can give you an information as to how to operate on these tumors. This is one of the most dangerous and most vascular tumors of the body. I am not sure if you can interpret what is this tumor. I don't have time, but I could have waited. This is cavernous hemangioma of cavernous sinus. This is the most benign tumor of the body, of the cavernous sinus. This tumor is the most difficult neurosurgical tumor. It is a very heavily vascular tumor. More important is that it is entirely within the confines of the cavernous sinus. Never it goes outside the dura of the cavernous sinus. In 1991, this was the case I published with pre-op and post-operative image of this tumor. Before this, 1991, there were very, very few reports, if at all, showing pre-operative and post-operative images of cavernous hemangioma surgery. So lateral wall is intact. The tumor goes towards the intercavernous sinus, goes towards the orbit, goes towards the Meckel cave. Never this integrity is destroyed. It encases the internal carotid artery. No matter how big it becomes, no matter, the dura will remain intact. Intercavernous sinus extension will always be there. The cavernous extension towards the Meckel cave, towards the orbit, internal carotid artery is encased by this tumor. The sixth nerve is encased by the tumor. That makes the surgery difficult and complex. So we described in the year 2000 my experience with 13 cases, which was very large experience at that time. Now my experience is 38 cases with cavernous hemangioma. for the first time in the literature, we described an extradural approach to these tumors, extradural. And subsequently, several groups had described, but this was the first article described in the literature where an extradural approach to cavernous hemangioma was described. And no question, the whole world now likes to do extradural approach for these tumors. So this is the tumor, and this is the extradural operation, and this is the only, there is no other treatment. You have to do surgery. If you have to restore the eye movements and the ptosis after 3 months of surgery, the eye movements have returned and you can bring a beautiful smile on this lady. Only one strategy of treatment is that you have to resect it radically and you have to resect it completely. No matter how big this tumor becomes, it encases the internal carotid artery. The tumor extends towards the intercavernous sinus, and this is the flow-related aneurysm, very heavily vascular tumor. If you have the guts, if you know how to control the bleeding, if you can understand these tumors that they will never transgress the dura here or dura here or dura here, completely within the cavernous sinus, you can remove this. I removed this long time ago and I published, and here the aneurysm also has been clipped. This is another tumor, never it will transgress or violate the dural confines, and these tumors are most benign tumor. As soon as you remove this tumor, the headache is gone and the person returns back to normal life. I have the video here, but because I have only 90 minutes to show you this whole presentation. So this is first thing for an extradural. This is the posterior, this is anterior. First thing is cut the meningeal artery, middle meningeal artery, and then you can do extradural approach. Then what you have to do, peel off the dura. You have to know how to coagulate and when not to coagulate. Many of these tumors, even if they are vascular, you cannot go on coagulating and coagulating, because if you go on coagulating, you will never end. The surgery will never end. And this peeling, you see the peeling of cavernous sinus wall is a very effective way to open the lateral wall of cavernous sinus, and then you see with how I'm doing blunt dissection to expose the lateral wall of the cavernous sinus, which is still encasing the fifth cranial nerve dura. And the entire lateral wall can be exposed for this very, very heavily vascular tumor. And now, once you have exposed the lateral wall completely, you have to expose for these tumors. Exposure is a very key thing for any operation. And for this operation, you don't have to open the brain. You don't have to come intra. So this is the V2, this is the V1. I'm trying to expose. You see how it is bleeding this tumor. You cannot actually, if and this, I have to tell you that the whole operation is almost non-edited. And I do many of these cases in a very, you see the red colored tumor. First thing that you have to go is to get to the sixth nerve that you have got here. Identify the sixth nerve, save the sixth nerve, and isolate the sixth nerve, and then go further in the dissection. And once you remove the tumor, once you get a very panoramic and things like that. This is a very doable operation. It will bleed, and it will bleed furiously, and you have to get ready for that. Now I will go for a very common subject that we all deal. Giant pituitary tumors and pituitary tumors. I have to say that our information of dura has completely revolutionized pituitary tumor surgery, and I will show you how. And there are several articles of mine in various books and various journals. I will invite you to read these articles. And these articles, I am going to show you how the concept of dura has completely revolutionized this common subject of pituitary tumor surgery. These are giant pituitary tumors. They have a very defined dural relationship, which I am going to show you. These giant tumor, they have madness, but there is a method in this madness, which I'm going to show you. I divided pituitary tumors into 4 grades. Now you carefully look at these slides. I said for the first time in the literature that the diaphragm celli is elevated by the tumor, and diaphragm celli, the dura of the diaphragm celli is not transgressed by the pituitary tumor in most cases, in grade 1 tumors. This understanding that the dura is elevated has completely revolutionized pituitary tumor surgery. Whether you use endoscope or microscope, that is a different, minuscule thing. Dura is elevated by the pituitary tumor. So you operate here, 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 you remove the tumor, dura will ultimately come into the field. This concept I introduced in the year 1992 or 93, and there is no question this concept has completely changed how to do pituitary tumor surgery. You will not imagine majority of these tumors in the 1995 or 94, during that time, all of these tumors were done transcranially. Dura is preserved, and even there is a nubbin of dura around this part of the tumor, it is not transgressed. This kind of configuration, it is the dura is preserved and is not transgressed, is a very important information. Dura is going inside the brainstem, but this dura demarcates the tumor from the brainstem. This information is very critical. Grade 2 tumor is when the tumor goes in the cavernous sinus, the lateral wall of dura is preserved, the diaphragm is preserved. These are grade 2 tumors. Grade 1 tumors are less aggressive than grade 2 tumors. Dura of the lateral wall is preserved and the tumor goes in both cavernous sinus. How some tumor go in cavernous sinus and why some tumors do not go into cavernous sinus is a matter of discussion, and we have published on this. The medial wall of cavernous sinus is a great wall, almost an impermeable wall, but some people have the how to enter into the Great Wall, like Great Wall of China. Some people knew how to transgress the Great Wall of China. So this tumor has that power to transgress. So grade 2 and grade 3, carefully look at these slides. This tumor has gone into cavernous sinus. This tumor has elevated the dural roof of the cavernous sinus. It is still within the cavernous sinus. You must remember, it is still within the confines of the dura. Dura is elevated, but it is not transgressed. Diaphragm is elevated, dural roof of the cavernous sinus is elevated, lateral wall is displaced, not transgressed. Beautiful. For the first time in the literature, we mentioned that the dural roof of the cavernous sinus is elevated by these tumors. These tumors I call grade 3. Grade 3 tumors are more aggressive than grade 2 tumors. Dural roof of the cavernous sinus, diaphragm of the sella, and dural roof of the cavernous sinus, beautiful trifoliate tumor. It is very rare that the dura of the diaphragm is transgressed by these tumors, and in circle of Willis is encased. If you have this information, you can do pituitary tumor surgery without going transcranial, and you can do a beautiful job and an extremely quick job. I must tell you that many of these tumors I do in 20 minutes or 30 minutes operation, and it's possible. And it is not too much to say that this tumor is quite a rather simple tumor if you know one thing, and that thing is that the dura is intact. If you know one thing, that the dura is intact, this information is quite critical. Dural roof of the cavernous sinus. This understanding has completely, as I have repeatedly mentioned, quite an influence on the way we operate pituitary tumors today. So this tumor, you don't have to remove the planum sphenoidale or tuberculum celli. You have to just remove the anterior wall of the sella, break into the tumor. These are soft tumors. You break into the tumor and debulk the tumor, and you know the art. You have to know how to do it. You have to learn how to do in bleeding territory, and the whole diaphragm will come into the picture, and the tumor is gone, and the patient gets a new life, a new vision for his life, and a new way how to live. These tumors are like this uterus. Uterus is the strongest muscle of the body. You'd never have to do cesarean section. You should not do. No animal, no elephant, no donkey has ever undergone a cesarean section. It is only a donkey of a human person who prefers to do cesarean section for this beautiful and ignores the powers of the uterus. Similarly, for these kind of tumors with pregnant baby, there is no need to come transcranial. This is a real-time, quick operation, soft tumors with necrosis, and you can have a beautiful outcome in a very quick time. These tumors have, there is subfrontal extension was the indication for transcranial surgery at that time. I have to tell you, under no circumstance, this tumor should be removed by transcranial route. Even this kind of extension, no need to come from here, no need to come from here. Just remove this anterior wall and start breaking the tumor, and you have to know that art, how to do and break the tumor. You can imagine in 2001, I did this tumor 20 years ago. You see this diaphragm cell is with the information that diaphragm is going to be present. I did this tumor in 2001 and gave a new life to this person in the immediate post-operative period. He said, "Doctor, what a fantastic vision I have got, and what a fantastic doctor he was seeing." This was another case I did in 1999, 21 years ago. You see, this was the tumor, the information if you had that this tumor is within the dural confines. I removed this tumor. This is immediate post-operative scan where there is a lot of blood, but this patient, this post-operative blood will always be there in such large tumors. But this patient was a young man, and I removed it completely by just removing the anterior wall. Cavernous sinus extension for pituitary tumors which extend like this, you have to follow the tumors. You have to follow many of these non-functioning tumors. You don't have to remove in the intracavernous portion, but functioning tumor, of course, you have to remove. Transsphenoidal, you have to know how to enter into cavernous sinus. Some tumors are, many of these tumors are soft. Many of these tumors have to be removed, like Cushing disease, acromegaly, cannot be controlled unless you remove the cavernous sinus portion of the tumor. So this is the elevation of the roof of cavernous sinus. When you remove this, when you have this residue, these tumors are very prone to recurrence. So this understanding that the dural roof of the cavernous sinus is elevated, you can remove this tumor. In 2002, I removed. So understanding of the dural configuration is critical. And this kind of tumor, which is grade 4 tumor, encases the artery of circle of Willis, you have to have a different attitude of surgery. Now I go to another tumor, which is my favorite tumor. I described this 73 cases in 2003. Now my experience is nearing 300, which is the largest experience in the world. This article showed that the tumor, this article showed for the first time in the literature that these tumors arises from the Meckel's cave, first thing. Second thing, in this article, which is very heavily cited article, showed that the sensations of the trigeminal nerve can be preserved in trigeminal neurinoma surgery, first time in the literature, as a series. There were some isolated reports, but never as a series. And also for the first time in the literature, we showed that this part interdural between the layers of the dura, and understanding this mechanism or this relationship completely revolutionized trigeminal neurinoma surgery. In the year 2003, I said that this part of the tumor is subarachnoid like acoustic, but then we said subsequently that even this part of the tumor can be interdural in location. So we did this operation in 1995, 25 years ago, infratemporal fossa interdural approach. During that time, I must tell you, cavernous sinus surgery was very difficult and dangerous, and very few people, even today it is difficult and dangerous, and even today very few people are doing. But in 1995, I did trigeminal neuronoma surgery by interdural approach, infratemporal fossa, without doing any craniotomy. So this was the first time a cavernous sinus surgery was done without craniotomy. So this, in my paper, this was one tumor which was done without craniotomy, and this was another tumor which was going in the posterior fossa like this, and I removed without craniotomy with just opening the foramen ovale and widening it. So this was another case I did without opening the skull. So these tumors, trigeminal, are interdural tumor. This understanding completely revolutionized trigeminal neuronoma surgery. And many of these tumors, believe me, I do in very quick time. I should not say 20 minutes or half an hour, but not more than 1 hour, this operation can be and should be done. Before we described, many of these tumors were done in 2-stage, and 2-stage operations were very commonly done during those times. And in 1991, I used to do 2-stage operations. So I did first middle fossa and then posterior fossa, 2-stage in 1991. 1992, I did this case 2-stage. First, I removed this and then I removed this. But then as our understanding increased and our basic understanding of skull base in general increased and improved, and then we understood the dural configuration, then I started doing this basal work, removal of root of zygoma, removal of roof of condyle, roof of external ear canal, partial mastorectomy. I used to do these kind of exposures I described in 1996, but then I reduced my exposure. Just this is my current, just splitting the temporalis muscle, working small craniotomy here, go into the extradural, interdural, and you can remove these tumors, as I mentioned, in very quick time if you learn how to respect the dura, learn how to break the demolishing the tumor. If you know how to demolish without much coagulation, you can save the fifth nerve fibers in a very beautiful manner on a consistent basis. I will say today that if your facial sensations are gone following trigeminal neuronoma surgery, you have done great harm to the patient in general. You cannot have a patient losing his corneal sensation after surgery, and you have to know how to work within the dura and how to demolish this tumor in a very quick fashion and in a very judicious fashion, in a respectful fashion to the dura and to the carotid artery will always be displaced by the dura. You don't have to have proximal control. And even when the tumors go extracranial, this is V1, V2, V3, the dural configuration is always present. We described this dural configuration in 2010, and on the basis of 28 cases, extracranial extension, and we described a transcranial route to remove these extracranial tumors, which was reverse skull base tumors, reverse skull base approach. Similar to Gasserian ganglion tumor, trigeminal nerve tumor arises from the Gasserian ganglion, which is the largest ganglion in the body. Similarly, C2 ganglion is the largest ganglion in the spine. C2 ganglion is unique, that is extraspinal. It is outside the spine, behind the C1, C2 joint. It is between the dura. Tumor arises, C2 nerve tumor arises in the ganglion, and it is between the dural layers. So we describe this is C2 neuronoma, like trigeminal neuronoma, between the dura, and I had described first that this is intradural and this is interdural. On the basis of an experience with 60 cases in 2008, I said that this is intradural, this is interdural. But in 2018, I described additional 50 cases. I said that even this part is interdural in location. And believe me, this concept has completely changed my personal dealing with these tumors and the rapidity of performing of these operations. So this is C2 neurinoma, trigeminal neurinoma, work within the dura, and you can do these operations in a very quick time. Now I want to take you to third nerve neurinoma. Third nerve neurinoma are dangerous looking tumors. You see, dangerous looking, but I will give you one magic how to remove third nerve neurinoma with the concept that the dura is present around these tumors. This we published several years ago, that oculomotor nerve tumor arises from the oculomotor cistern, and the dura is, it takes the dura along with. It is not the capsule of the tumor, but this is the dura. Work within the dura, demolish the tumor, learn the art of breaking the tumor, and you can save the third nerve and improve the third nerve function after the surgery. First time in the literature, this origin has been mentioned, and this concept of preserving the third nerve has been mentioned. Dura is present along the third nerve. Break the tumor, but preserve the fibers around the caps inside the dome of the tumor. This is sixth nerve tumor, which is the most unique tumor, and I'm still trying to analyze the dural relationship of the sixth nerve tumor. Similarly, seventh nerve, these are very complex skull-based tumors. This is seventh nerve neurinoma. If you do not know the dural confines of this tumor, if you do not know how these tumors originate, this tumor arises from the geniculate ganglion, and they remain entirely, whether they go in posterior fossa or in the middle fossa, interdural in location. I can tell you several of these cases can be done in less than 1 hour. Is too long an operation. But work within the dura, try to save the fibers of the seventh nerve, which go on the medial aspect towards the petrous apex, and in its course towards the mastoid bone. You can preserve and improve the facial nerve function. This is what we describe for the first time in the literature. Interdural approach, respect the dura, respect dura mater, respect dura mother. Another beautiful thing I really recently described, interdural approach to lower cranial nerve schwannomas. So we described that lower cranial nerve schwannomas arise within the jugular foramen, and they retain the dura around its complete entirety. Even extradural part is within the dura. And if you respect the dura, you can save the lower cranial nerve, and you can improve the function of the cranial nerve following surgery. This is the trick. If you do not know, if you try to remove it as a capsule, then you completely demolish the lower cranial nerve certainly. But you can certainly preserve and improve the lower cranial nerve function if you know how to preserve the dura. Another beautiful and common tumor for the skull-based surgeon is a clival chordoma. These tumors we described that these are entirely extradural for the first time in the literature. We described that these are tumors which demolish the bone but displace the soft tissues for the first time in the literature. They displace the carotid artery anteriorly. They displace the cavernous sinus superiorly. This concept makes your surgery very beautiful and philosophical. You see, when you come from lateral, there is no carotid artery here, no cranial nerve here, and you can come from this direction, and there is no brainstem here, no basilar artery here if you know how to respect the dura. Carotid artery is displaced anteriorly by the tumor. I described in 1995, and believe me, this is one of the most fascinating papers of mine, that the dura is displaced posteriorly and the cavernous sinus is displaced superiorly. On the basis of these concepts, I described middle fossa subgacillan ganglion approach to clival chordoma. Beautiful approach, most philosophical approach I described in 1995. Come from lateral, artery is anteriorly dislocated, cavernous sinus is superiorly dislocated, basilar artery is posteriorly located, protected by the dura. You see, this tumor looks horrendous and difficult. Carotid artery is anterior, dura is here. You can come and work within the dura, and you can remove this tumor beautifully in quick time. Recently, I just want to show you, recently I described supracerebellar approach to some clival chordomas. You will never like to do this, but when the tumor comes too much behind, for the first time, beautiful thing we mentioned in this article, that the sixth nerve is loses its companionship with the carotid artery and traverses on the dome of the tumor. So you can protect the sixth nerve by working in the anterior aspect of this tumor, and you can do by a supracerebellar approach in some selected. Of course, these are extradural tumors. You have to come extradurally to remove these tumors. But this is one option that you can use, supracerebellar, for some tumors which are quite in the posterior fossa like this and quite in the clivus like this. You can remove supracellular. Now I want to talk to you about meningiomas. Meningioma is my very favorite subject, and I have spent my whole lifetime treating meningiomas. So this was one tumor I removed in 1995. 1995, I removed these tumors. This is cavernous sinus and petroclival cavernous sinus meningioma. I removed long time ago. And I damaged the patient by having this patient develop hemiplegia following surgery. Young man at that time, he's still alive with hemiparesis. Now he walks with a stiff gait on one side, carotid artery, preservation, safety of cavernous sinus vessels, safety of the cranial nerve is crucial issue that we have to learn and respect. And you cannot do cavernous sinus surgery unless you learn to protect these nerves. So one beautiful editorial I wrote in Journal of Neurosurgery, I would like to invite you to read this editorial, beautiful editorial as to how to deal with cavernous sinus. So I just to give you some philosophical issues about meningiomas involving cavernous sinus. This is a convexity dura based meningioma. This is a benign meningioma, according to me. When it goes into the superior sagittal sinus, it is more aggressive. When it involves the superior sagittal sinus, it is more aggressive in its behavior than a convexity meningioma. When it involves the superior sagittal sinus and involves the gallia and the bone, it is more aggressive in behavior. When it goes and involves the paranasal sinuses, it becomes nearing malignant nature. When it breaks the bone, goes outside, it is more aggressive in behavior. When it is located in paranasal sinuses, it is almost like a malignancy. Similarly, when the tumor is on the lateral wall of the cavernous sinus, it is like convexity dura based meningioma. When it goes inside the cavernous sinus, it is inherently more aggressive in nature. So this meningioma, which is on the lateral wall of the cavernous sinus, is less aggressive. When it goes inside the cavernous sinus and it is outside, it is inherently more aggressive. I am not saying it is malignant, but it is more aggressive. We should have that information in our mind. And when it goes and involves the sphenoid sinus, it is much more aggressive in nature. Purely intracavernous meningioma are more aggressive than tumors arising from the lateral wall. I removed this tumor in 1995. There was a recurrence in 2001. This tumor is more aggressive because it is going into the paranasal sinuses. You must remember that we are dealing with a tumor which is nearing malignancy. And without question, when the tumor goes and involves the eyeball like this, it is a malignant tumor, even if it is a meningioma by name. So these tumors which arises from the lateral wall are relatively, I should not say easy or straightforward. These are good tumors to operate, and behaviorally they are much better than a tumor which goes inside the cavernous sinus. So these tumors are better. So this tumor arises, meningioma, from the posterior wall of the cavernous sinus. This is post-operative. I had removed several years ago and complete. This patient is a custom officer and still working with no problem at all. This are relatively straightforward. When the tumor goes into cavernous sinus, it becomes more tricky. But tricky means it is not that we will not go into cavernous sinus, cavernous sinus. You have to follow the tumor as long as you can be safe. As long as you can say, I will preserve the cranial nerves. If you damage the extraocular movement, it is as good as damaging the complete eye. I'm not saying you cannot damage. I have damaged several oculomotor nerves, several sixth nerve in my career, but it is a complication. And you have to learn to handle those complications, and most importantly, learn to avoid those complications. Posterior clinoid meningiomas are more beautiful tumors than tumors which go inside the cavernous sinus. So this is one petroclival meningioma. A small part of the tumor was left behind in the cavernous sinus. Leaving behind cavernous sinus tumor is not a bad thing, but if you can remove, it is better. But if you cannot remove, it is not a crime. I will say to be philosophically understand this lot of tumor behind. And I wanted to do second stage, but this patient was completely asymptomatic for a long time, still asymptomatic for several years after surgery. You have to know when to remove and how to follow the tumor is one thing, and how to follow the symptoms is another thing. I used to do very aggressive tumor bone work, mobilization of the facial nerve, mobilization of the carotid artery. There are several articles of mine where I move the facial nerve, cut the GSP and mobilize the nerve and do very aggressive exposures. This tumor I did long time ago with very aggressive exposure, but now my exposures have become less. See this tumor and post-operative scan. But for several, no, I'm not saying for several petroclival meningioma, I like to do a relatively less aggressive exposure by supracerebellar approach. I have now got several cases. I described 28 cases in 2004. Now I think I must be having more than 150 or more cases I did with supracerebellar approach. Beautiful approach for several of these tumors. Even when the tumor goes up, you can remove this tumor by supracerebellar, goes towards the cavernous sinus, you can try to remove, and you from a very selective, you see this tumor in the cavernous sinus, you can come in this direction and remove this tumor. I'm not saying you can do it all the time. You may not be able to remove, but you have to have that feel that, yes, I have to remove this tumor. This is petroclival removed by supracerebellar. This is the same case I showed you earlier. This is the tumor going in the cavernous sinus, removed by supracerebellar in very quick time. I must tell you, in neurosurgery, that is one thing you should never say that I do in quick time and I do quickly. That is the last thing in your mind. But with your experience, with your ability to work within the dura, with the ability to respect the dura, with the ability to understand that you don't have to completely clear off if some tumor is left here and there, it is not bad. But your attitude should not be bad. Your attitude should be towards radical complete resection, and you can remove several of these tumors in very quick time. And this is the preoperative and this is the postoperative image. This is the removed in very quick time. Petroclival meningioma, just to show you a brief video of this. This is the postoperative showing the cranial nerves and things after this radical tumor resection. This is another, this is preoperative, and some tumor was left behind in the cavernous sinus. This is the, I don't want to show you too much dissection here, but showing you the complete resection of this tumor possible with the supracellular. Just I want to introduce to young people supracerebellar approach to these kind of very complex tumors, which can be done in very quick time and have a very big, huge exposure. And as I have mentioned now, on several occasions, I do this supracerebellar, and a very fantastic exposure is possible. Just quickly show you the end of this operation as to how I am exposing the basilar artery and the vertebro-basilar complex. And this is, of course, the terminal stage of the operation. Now I want to just briefly touch on various meningiomas. This is tuberculum celli meningioma I described in 270 cases. Now my experience is the largest in the world, more than 300 cases. Olfactory group, this was the largest series ever published in the literature. And foramen magnum also, this minimal reduction. You see how I have reduced in 2001. I showed that you can do midline posterior approach for these tumors, even located anteriorly. You can do quick. Even the most complex foramen magnum ossified foramen magnum meningioma. Let me show you some ossified tumor. This is bone tumor located anteriorly, bony tumor, encasing the vertebral artery. I did by midline posterior approach this complete resection. Dangerous tumor. You see this bony tumor encasing both vertebral arteries, and I have done by posterior midline approach for this complex tumor. This is another bony tumor. You see bone encasing the vertebral artery. This is postoperative. So what I want to show you is that as you learn, as you grow with more experience, you should know the art of demolishing the tumor. That is one. You should know the anatomy of the tumor. That is two. You should know the dural relationship of the tumor and how these tumors will respect the dura and how you have to work in the membranes. Beautiful 3 sentences I want to give you regarding meningioma. That curing, you can never cure. You do whatever Simpson and whatever zero Simpson or minus zero Simpson, but you can never cure. So curing is non-issue in the treatment of meningioma. Recurrence of meningioma is independent of extent of tumor resection. It is not the treatment, but the cellular behavior of the meningioma that decides the outcome. Extra, these nasopharyngeal tumors, just I want to touch. Nasopharyngeal tumors are outside the dura and outside the skull. Nasopharyngeal angiofibroma should be removed from the nose, or mid-facial degloving operation is a good operation. These are extradural and extracranial tumors. I had described transcranial route for the first time for nasopharyngeal angiofibromas, but I will in 1994, but I will not recommend it. I like to do mid-facial degloving. Epidermoid tumors are also very membrane-friendly tumors. They remain in selected group of membranes, and I have got several epidermoid tumors of the cavernous sinus. Aspergilloma can sometimes be mistaken as a meningioma. This I had published several years ago on 2 cases, but I have got several cases of aspergilloma. I have got mucous, various other fungus. This is tuberculoma involving the cavernous sinus. Reconstruction after skull base surgery is a very important thing. You should know the membranes of the scalp and membranes of the skin and membranes of the dura. I had described the subgaleal fascia as an additional layer, and there are several articles of mine discussing vascularized pedicle reconstruction. I have got some 12 or 13 flaps which I have described. You must read if you are interested to read this reconstruction. Vascularized reconstruction using vascularized mucosal flap was described in this article. How to use outer layer of the dura as a pedicle flap. Recently we described another with my associate. We have described another layer. So in short, we must remember that we are not gods. We are human beings. But we can become better human beings by changing our attitudes, by respecting our seniors, respecting our mother, respecting our teachers, respecting our tumors who are our teachers. Tumors teach us. Tumors give us messages, and neurosurgery, one day we are very high, the next day we can be extremely low. We can create a complication out of nothing. Every neurosurgeon should have a plaque in front of his clinic stating that there are some patients whom we cannot help. There are none whom we cannot harm. Thank you very much, my dear friends. I hope you have got some wonderful messages from this lecture. Thank you very much. So over to you, Sanjeeva.
Atul, thank you for, again, absolutely fantastic presentation, a real tour de force of the cavernous sinus. Thank you. I'm just going to ask one question while I look through what the questions that I'm sure are coming through for everyone. What would you recommend, Atul, as for someone who's starting out in cavernous sinus surgery?
See, cavernous sinus surgery is not for starting out people.
Indeed.
You have to start out one day. Someday you have to start out. But you have to start out after a proper infrastructure. Building has to be made. You cannot jump and start making the doors and windows of the for the cavernous sinus surgery. You have to make a foundation first. You have to dig the ground. You have to make the foundation. You have to dig, you have to learn the anatomy. You have to learn anatomy several times over. And you have to have the experience of dealing with several brain tumors, several extradural tumors, several intradural tumors, convex tree meningiomas. Once you are ready, you are ready. You have to come with a bang. You cannot say, I will start cavernous sinus surgery first day. But you have to learn, and you have to be junior, and you have to develop and progress, and you have to become big. You have to mature into cavernous sinus surgery slowly, surely, but definitely.
I think that's very well put. That's all very well put. John, I see you've come up on the screen. Are there any questions from our participants for Professor Goel or all of any of the panelists? Please type your
My dear
questions in.
John has come, it means it is time to wrap up the show.
There was
John,
one
come.
question here.
No, I'm not coming up. Anyone can ask a question.
What are the,
Okay,
they asked what are the top 3 tips for debulking a tumor? I think you made a very nice point there, Toll, about, you know, everybody talks about the beautiful arachnoidal dissection. We talk a lot about the drilling and all of that, but actually a big part of doing these sort of operations, difficult areas, is really getting the volume down, isn't it? What are your tips? Maybe
My
for
tip
relaxing
is,
the
you know
brain,
what,
getting the tumor down?
tip is learn to assess the quality of the tumor, whether they are soft tumor, whether they are firm tumor, whether they are necrotic tumor, whether they are vascular tumor. You learn to demolish the tumor. If your art of demolishing the tumor is by coagulation and continuous bipolaring, many a time you can spend hours and hours without moving an inch ahead. You have to learn to break the tumor and coagulate at specific targeted points rather than all over. As soon as it bleeds, you know, many of these tumors, like I was talking about cavernous hemangioma of cavernous sinus. If your attitude is to have a clean field, if your attitude is to have a bloodless field, you can never do these tumors. You don't even go near these tumors because you can never do them. You will not believe, but many of these tumors, like pituitary tumors, giant pituitary tumors, there is no coagulation on my operation table. Many of these trigeminal neurinomas, I coagulate hardly during the operation. You can remove the entire tumor without a single coagulation during the operation. Here and there, some meningeal vessel bleeding, and you can do. Basically, it is not, I'm not stressing on the time factor that you do quickly or do rapidly. That is the last thing in my mind. But if you have the art of breaking into the tumor and you can do quickly, you can do safely, and you can protect the cranial nerves which are hovering around your field, surgery field. Like trigeminal nerves, I said, you have to save the trigeminal sensation. You have to save the V1. And if you don't save the V1, there is a complication at hand. Oculomotor nerve, if you do not save the oculomotor, I'm not saying you can save oculomotor nerve in all meningiomas, you can save the 6th nerve in all petroclival. Don't get me wrong. But our aim of surgery should be saving these nerves all the time. And if you say, I have removed the tumor completely and I cut the 3rd nerve because my tumor was not being resected, that is a very wrong understanding of philosophical understanding of the tumor. That is a message. That is why I say that total tumor resection and curing is not the aim of the operation. Radical surgery is the aim. You remove from your mind that if you remove it totally, you have cured the person. That is out of your mind. Like acoustic tumor, you have to keep in your mind that acoustic tumor, once there is acoustic tumor, it is always an acoustic tumor. You cannot cure the person of acoustic tumor. If you say, I have cut the facial nerve because I wanted to cure the person, there is no attitude worse than that. You have to save the facial nerve, and you have to leave some tumor. In giant tumor, I give one message to the young people. In large tumors, more than 3 centimeters, if you say, I have removed the tumor completely, zero, I have left all the tumor out, You are saying lies. You can never remove the tumor completely in a tumor which is more than 3 centimeter, and you can save the facial. You leave some tumor behind on the facial nerve. Always you keep that attitude in your mind that I will leave a sleeve. If you say I will do partial resection and all those things, that is, you will come out with 20% resection. You have to be aggressive in these tumors, but you should not be, you should be kind to the facial nerve and to the patient, because the identity of the patient depends. And you say, I will remove the tumor completely. That is absolutely ridiculous way of thinking. Sanjeeva, what is your message on this?
No, I agree 100%. I think you have to leave a tiny, particularly at the porous, and we're going off topic a bit on acoustics, but you're right, particularly at the porous, where the nerve really starts to thin, you usually have to leave a small amount. I agree fully. I want to come back to debulking, but I also want to bring our panelists in. So maybe I'll ask Professor Sanford about what his views on, he's talked about TIS-SEAL, and maybe you can, and you and Abira could comment too. Hemostasis while working in the cavernous sinuses is critical, isn't it? It's about understanding there are pockets of these venous sinuses and that you can control that and work in different locations. But maybe we'll ask Sanford first, Atul, and then we'll come back to you. Sanford, what are your tips for controlling hemostasis in the cavernous sinus? Oh, he might not be here. Atul, why don't you start us off?
I don't like to seal or any artificial thing. Tell you the truth, I don't want to say you are wrong. I don't want to say you should not do. But if you are asking me, I have to tell you what I am doing. I don't do these things, and I don't believe in putting TCL and artificial material. I put some Surgicel here, Surgicel there. You know what? You have to know what to use at what time, when to use coagulation, when to avoid any kind of coagulation or anything, when to use bone wax, when to use Surgicel, when to use gel foam, when to use pressure. These things form the basis of neurosurgery. These things form the basis of our entire life of tumor surgery and of our neurosurgery. And we have to learn as we go progress further and further and further in our life and in our career of neurosurgery. We know how to handle, because one neurosurgeon is different in the attitude towards bleeding as regards another neurosurgeon. One neurosurgeon, if the bleeding starts, he will shake and he will be terrified. Other person will be cool and composed. It is not just the attitude. One person will start, take bipolar in the hand and keep on burning all over the place. Other person will do another attitude. So how I differentiate one neurosurgeon from the other is his response to bleeding. Is his attitude when the bleeding occurs, what attitude he changes and he adopts. That is what makes one surgeon different from the other and in the entire field of neurosurgery. I don't use TISL.
So you would favor Surgicel, or as you say, you have to make progress sometimes in these cases. Is Sanford still on this call? Professor Sue, are you still here? Can we unmute? John, can you tell me, is he still here? He looks like he's still here. He might just be out of the room.
No, what are you looking for?
Sanford.
He is here, but he is muted. I think he may be out and left because it's too late for him.
No, absolutely. It's very good of him to join us so late. Okay, well, maybe we'll take one more question and then we can come to a close. It's been an excellent session. Obviously, the length of time may be affecting some of our participants who are in different parts of the world. So we'll take a question here from Gianluca Grimaud. Well, this will be interesting, Atul, what you have to say about this. This is something we use in Oxford. The question is, would you recommend radiosurgery for certain cavernous sinus meningiomas? What is your view on that, Atul?
Yeah, that is a difficult view to, but I will say, I will invite this person who is asking this question to read my editorial, which I had placed on the screen during my lecture on cavernous sinus meningioma, I will invite him to read. So in short, my attitude towards using of radiation is, as long as I think my knife can work, as long as I think my knife can reach the tumor and I can remove the tumor, I will use my knife. But as soon as I think that using of knife can be dangerous for the patient and I cannot reach with my knife, I will say radiation. And if I leave some small residue behind, I will never like to give radiation unless I see a definite recurrence which I will not be able to reach with my knife. So knife first, gamma knife last, or maybe as a rescue mission, but never as a upfront, never. That is my
As long
answer
as
to
you
your
feel you
question.
can safely remove the tumor,
That's right. That's right.
you would.
Safety first.
Yeah.
And you know, in Sanjeeva, you can understand in neurosurgery, heroism is not a good word. Heroics will not work. Ego and pride will not work. It is good to be proud, but never have pride on your shoulder. You know, you can never go beyond a line. You have to work with your head down, with your feet firmly implanted on the ground. You have to work with heads down with respect to the nature, respect to the tumor biology, respect to the patient's needs. You can never start heroics. You know what? Just because, you know, a few days ago was the Hiroshima bombing day. And the one who designed the bomb, who made the bomb, Oppenheimer, I cannot pronounce that properly. He said that it was a technical wonder, but whether this technical wonder that killed so many people on the planet, whether that technical wonder was good enough, whether it was good at all, these were the words of this great man who made the atom bomb. Similarly, sometimes we do technically to give a good preoperative and postoperative picture. I show here is the pre-op and here is the post-op, but I don't show you the patient will hemiparesis or patient will third nerve or the patient will devastation of the face. You know, it is not the technical heroism which matters. It is the result that matters in our subject, in our great subject of neurosurgery.
You're absolutely right, Atul. I think that's a beautiful note to finish on, and something for all of us to think about during our career. So thank you very much. I think the person we really must also thank is Dr. Sameh, who's lined up an absolutely fantastic lineup of speakers. So Dr. Sameh, well done. You've invited world-class speakers. It's been a fantastic session. I've learned a lot. I hope everybody joining us today has also learned a lot. Just to run through again for you, we had beautiful dissections at the start from Dr. Abiha, and then we moved on, Professor Sanford showing some very complex, great systematic approach to working through building up your skills, and then finally the tour de force from Professor Goel. Very impressive lectures, all three of them, beautiful lectures. It's been a real pleasure to be able to join you today. As I said, I've learned a lot. I hope everybody else did. And Dr. Sameh, well done. It's a lot of hard work doing this. Thank you very much.
Sanjeeva. One thing I must tell you, that you are working in Oxford, which is the mecca of entire, you know, we are waiting for the vaccine to come from your center. And I hope the Oxford vaccine will kill the corona and make us all strong and able to handle the corona. So you're working in the center which is making the vaccine. And I'm sure you are doing some remarkable and wonderful neurosurgery. I look forward to visiting your center. And like you, I thank Dr. Sameh, who is building up this huge power force of neurosurgical encyclopedia and neurosurgical force. There is no question, you know, this symposium is being watched by so many people other than what you see the numbers on the screen. Dr. Sameh, you will slowly and surely build a great University of Neurosurgery. My best wishes to you, Dr. Sameh.
Absolutely. Thank you. Thank you very much, everybody. That's well said.
Thank you, dear professors, for attendance and great lectures that you have honored us. And thanks, Professor Sanjeeva, for amazing moderation for such a great session. Last announcement, for all panelists and professors and attendees. Wait for us for next session. It will be 4th and 5th September at the same time of this lecture. Keep the date and the links will be available on main group of Owens Academy. Have a nice day. Thank you. Thank you.
Thank you very much. Take care.
Thank you, everybody.
Thank you.
Thank you, John. Thank you so much.
Thank
And
you, Atul.
See you soon, John.
You're the best, Atul.
Thank you. Thank you so much. Thank you, John.
Thank you, all of them.
Bye-bye.
Thank you. Thank you very
Bye-bye,
much.
everybody.
Can I
Bye-bye.
have a small comment, please?
Yes.